A very good afternoon to all the participants, and it is my privilege and honor to welcome yet another distinguished speaker among us, Dr. Sumit Malhotra. We are colleagues from All India Institute of Medical Sciences, and we have many a times formally, and we have met formally.
Dr. Ashwini, you got muted.
It gives me a good afternoon to all the participants and good afternoon, Dr. Sumit. It is my pleasure to welcome you for the fourth day workshop on analytical techniques for statistical analysis and mental health. And Dr. Sumit is our colleague from All India Institute of Medical Sciences, working in the Center for Community Medicine. And uh, Dr. Sumit is a trainer of several research methodology courses and published widely in community-based research, and he has led health system-based projects evaluating the performance of national health initiatives at district and block levels, and is also the nodal person for Innovation and Learning Center and strengthening the implementation of comprehensive primary health care in the district of Mewat of Haryana. Dr. Sumit is currently the nodal person for organizing training and workshop on operation research as a part of a Department of Health Research scheme for human resource development of Indian Council of Medical Research. He has also designed, along with a team of persons from the World Health Organization, a course on program management for district and block-based program managers involved in the implementation of national health programs. He is also currently part of AIMS technical support on the cause of death ascertainment through verbal autopsy system and anemic Mukt Bharat at the Center for Community Medicine, and he has contributed significantly to national public health programs. His areas of interest include operational and health system research, community-based intervention trials, adolescent and school health, chronic care, including mental health, primary health care, sexual and reproductive health, neonatal health, and literacy. And I really admire Dr. Sumit's approach of engaging the participants, and he has a special art of teaching in that way. So, with these words, it is my honor to and privilege to welcome Dr. Sumit on behalf of organizing committee of Department of Psychiatry and National Drug Dependence Treatment Center for this DST-SERB sponsored workshop under the accelerated scheme. So now it is I give the floor to Dr. Sumit to kindly take over the proceedings forward.
Thank you, Dr. Ashwini, for a kind and a warm welcome. Very good afternoon to everyone. So, I think the topic for today's, discussion for the next couple of hours is going to be about categorical data analysis. Now, before I actually, start my presentation and talking about this particular subject, um, what I would like to ask, what kind of variables we are aware of. So I know it's a long, group. It's a very, um, wide audience, but then still, I think it'll be good to be connected. I hope I am being heard now. I saw a chat message that I need to be a little bit louder. So I hope that you can hear me. Can somebody
Yes,
indicate?
sir. Yes, sir. Thanks a lot, sir.
Yeah. Thank you. Yeah. So can any participant indicate what kind of variables you are aware of? You know what is variable? Variable is nothing but anything that varies. From an individual to an individual. In in human participants, if they are the participants, so anything that varies. So my question is, are you aware of some kind of variables? What variables are you aware of? That is my question, which is being asked, and I'm opening the floor so that at least you can open, at least you can speak something. And yeah. So I saw the response. It's dependent variable, categorical variable, continuous variables. So rightly being said, yes. So another response is categorical and continuous. Yes. So we talk about the variables as, largely classified as, categorical and continuous, uh, and we have many characteristics which have to be studied, and it will depend upon, the focus of the study, and what exactly uh, are the research questions that are going to generate potentially, the kind of variables. But by and large, there are certain variables which are always studied in human studies, right? So of course, when we will enroll study participants into our study, we will be asking them some kind of their details, which could be, their age, their gender, uh, you know which place they reside in, which state they belong to. So all of this is something which is very, very uh, basic thing. So a variable is termed as categorical, if that variable has categories in its responses, right? So, for example, you ask somebody's gender, so the gender can be classified as, men, women, or transgenders. So there are basically, three categories that we get. So, and there is no order here. So some of the variables will have an order, and when they will have an order, we basically say they are the kind of ordinal variables. But again, they can be classified as, the categories. And to exemplify, whenever we have a scale, and when we have a categorical scale, say suppose, uh, uh, very high likelihood of something and less likelihood of something, an average likelihood of something. So a category is like mild, moderate, severe, or when you are placing an order like first, second, third. So grading, whenever there is a gradient in a particular variable, so that becomes an ordinal scale. Unlike the other variables, which are continuous, which are basically measured in direct numerics, they become, quantitative, continuous variables, and you will have more, elaboration on the kind of statistical approaches to handle them, probably tomorrow. So I will, in the next, few minutes, we'll be talking about categorical variables and some very fundamental approaches to summarize that. So I see there is a question there, that what is the difference between nominal and continuous variables? So I mean, this is a very basic fundamental distinction that one has to know. So categorical variables, the variables which are going to be, categorized. So there are some categories. When the categories or the response categories have no order, they are independent, it becomes a nominal variable. Nominal variables will not be represented by numbers. You will basically say that somebody is a boy, somebody is a girl. So of course, when you will summarize them, you will say, suppose you have studied 500 participants. At the end, you will say, out of 500 participants, how many were boys and how many were girls? So boy and girl, if the response categories are these two, it becomes a categorical variable, which is nominal in nature. Whereas if you are, uh, say, measuring their body mass index also by measuring their, weight and height, and then you're classifying your study participants as, normal weight, or underweight, or overweight, or obese. Now there is an order here. So when there is an order here, it becomes the categorical variable, but with an order.
Dr. Sumit, sorry to bother you. Are you sharing your screen? We are not able to see your screen.
I haven't shared my screen yet.
Okay. Fine. Please carry on.
Yeah, so this is just an introductory, background to what I'm going to
Yeah,
talk.
sure. Please carry on.
Yeah.
We can give you extra time also, no problem. Please carry on.
Okay.
please.
I haven't shared my screen yet, and I haven't opened, my slides
Yeah,
Pandora
yeah.
yet.
Fine, fine. Please.
Okay. So, it's like, the order when we are measuring the body mass index. When we are measuring the body mass index, you have um categories as normal, underweight, overweight, obese. These are all basically categories with an order. Wherever there is a ranking, there is a gradient, it becomes an ordinal variable, so it's categorical. Now when you have a continuous variable, you have a number. Say you are measuring somebody's weight, you are measuring somebody's height, and you record it as a number. And that weight is ranging from, it could be depending upon your subjects. So suppose there are adults, say, and it varies from 30 to, say, within the participants that you have, say 105. So somebody can have 30, 34, 35, 38. So there is a continuum there. So it's a continuous variable. You usually calculate the mean of these kind of variables, right? So continuous variables, you will talk, we will hear more tomorrow, and we will discuss the statistical test and approaches tomorrow. So here we are largely are going to be restricting ourselves to the categorical variables. And now I share my screen.
We are able to see it.
Okay, thanks. So what we are going to talk about is about some measures. How do we measure, these variables in terms of frequency, and also in terms of measures of association? And that is what is very, very important. Say, for example, you are interested, to find out the prevalence of common mental health disorders in a community setting in adolescent age group. So I'm now referring to 10 to 19 years. And within that 10 to 19 years, which is the adolescent age group, I want to see and examine, measure through some standardized, study instruments for, presence or absence of common mental health disorder. So my main variable is presence of common mental health disorder, and largely I'm referring to depressive disorders and anxiety disorders. And I want to see within my population studied, say 500 odd uh, participants, what is the proportion that have these common mental health disorders. So, so my main frequency measure is going to be presence or absence of common mental health disorders. And again, I will categorize my all 500 odd subjects by this main variable. But I also studied their, other features, other characteristics. And I also measured whether in the last 3 months, was there any stressful event in their life. And so that is another variable. And I want to associate this variable, presence or absence of stress, with the presence or absence of common mental health disorders. So this, I'm now hinting at that I'm trying to measure the relationship between a stressful event in the last 3 months with the presence or absence of a common mental health disorder. So I will use some measure of association to find out this, kind of an association. So we are going to talk about some measures of association, and within different epidemiological study designs, we use different, measures of association, and that is what is something that we need to know. And similarly, we have some statistical tests which commonly are being utilized. So these days, the softwares are, great help to all of us, and we just through click of command we get the kind of statistical associations. But just to lay the foundation, I'll briefly discuss about some fundamental aspects related to chi-square test and the McNemar test, and some diagnostic test evaluation parameters. Very briefly, because all of this on its own, are entities which can be discussed in detail for hours. Now, what are frequency measures? When we talk about the frequency measures help us summarize the distribution of data. And the common frequency measures are ratios, proportions and rates. And all of these will have the basic structure in form of having a numerator and a denominator, and there is going to be a multiplier. And it will depend that the numerator is part of the denominator or it is not the part of denominator. Now, when we measure the uh, you know the morbidity, we basically can express that in the form of ratios, proportions, or the rates. And so the basic measures of frequencies are these depth, ratio, proportion, and rate. And when we are talking about the mortality parameters, there also we have, we can measure in terms of, or we can express all of these frequencies in terms of ratios, proportions, and rates. Now, these are the common examples of morbidity. So incidence, and we'll talk about this, later. We also have prevalence. So largely we talk about incidence and prevalence. And of course, the study designs permit us to calculate these parameters. I mean, in a simple epidemiological study design of cross-sectional nature, and the example that I was just referring to is that when we are interested to know the prevalence or proportion of adolescents having common mental health disorders, so what I'm going to get is the proportion of adolescents with these disorders, be it depressive disorders or anxiety disorders. And then I will say that out of all the people that I have studied, how many have uh, presence of depressive disorders, and say I basically used patient health questionnaire. I think somebody's mic got unmuted, so please mute yourself. Yeah. So thank you. So so when we are talking about the prevalence, so that's basically a proportion out of all the people that I've studied, how many have a particular characteristic of my interest. And when I said presence of depressive disorders measured by patient health questionnaire 9, which is the most common scale that we use, PHQ 9, or if it is anxiety disorders, we use generalized anxiety disorder scale, GAD 7. So when we say that how many uh, are above a particular score to say that there is a presence of either anxiety or depression. So that's the proportion, that's the prevalence we get in a cross-sectional study. Prevalence, most of the time we talk about as the point prevalence. Sometimes we do compute period prevalence also, but by and large, the prevalence is point prevalence in cross-sectional studies. Then we have the incidence. The incidence is number of new cases that occur, during a specified time interval, and there is a denominator which is there, which is population at risk. So, like for example, when we are talking now in a COVID-19 scenario, so we say every month or every week, what is the new cases of COVID-19? So we basically are measuring the incidence, and we can measure at the end the cumulative incidence also, whatsoever my period of time of interest is. Secondary attack rate is another measure. Again, it's used in communicable disease context, and just because that the COVID-19 pandemic is there, we can connect it better because all of us are affected in some or the other way. So, what's going on in a current situation? So say suppose there's a house and one family member get affected. Now we are interested that one person who is infected, spread the infection to how many more members within the same household. So from one secondary transmission to other subjects is something that we are trying to measure in terms of contacts. So that's the household secondary attack rate. So subsequent to the first case, how many more get infection, and that is what secondary attack rate is about. Now, incidence is a rate, and we will talk about what rate is, just a few minutes from now. There are some measures of mortality. Now, so rate is nothing, it has a numerator and a denominator. And what we need to know is that numerator is part of the denominator. It has a multiplier, it has a time frame, right? So always rate will have a time frame. And there are many rate parameters. Just to give you some examples, we have, crude death rate. Somebody died and others alive. So it becomes, in that context, how many died in your entire population, maybe in a year. So that is what is crude death rate. And over the period of time, the death rates are decreasing. But yes, we can also talk about death rates specific to particular context. Maybe in context of COVID, we can also talk about it. Then there is a cause specific mortality rate, like what or how many people are dying due to COVID. The number of deaths which is assigned to a specific cause during a given time interval is something which is very, very important. The number of people who are having uh, uh, kind of a serious mental health disorder. So they dying over a period of 5 years, could be seen as a mortality parameter in a longitudinal study design. Proportionate mortality is the mortality which is attributed to a particular cause, then it becomes cause specific. So proportionate is out of all the causes, what proportion is due to a particular cause. So that is the number of deaths assigned to a specific cause during a given period of time. And then we can have, case to death ratio or death to case ratios. So out of all COVID-19 cases, how many died. So that gives you the mortality which is there, and out of the total cases, how many are dying. So these are just a few examples to illustrate that these parameters exist. And in a typical reproductive child health framework, wherein mortality is basically measured at different age groups, you can measure it in neonates, less than 28 days of life, post neonatal period, infancy, maternal mortality within basically pregnant women. And similarly, we have more kind of parameters for rates. There are multiple rate parameters which can be measured. I mean, in fertility, in normal birth rate and death rate, and then there is low birth weight and things like that. Now, let's spend some time in understanding about incidence. Now, incidence is actually computed typically in cohort studies, in longitudinal studies, in follow-up studies. Now, be it prospective studies or be it retrospective studies, we calculate incidence. So, incidence is nothing but a number of new cases pertaining to particular disease. It could be an event, it could be injury over a specified period of time. We can express this as proportion, but typically incidence is considered as a rate. And as I mentioned, what rate is nothing but an entity which has got a numerator or a denominator. A numerator is the part of denominator, and it has a multiplier and it has a time frame, right? Now, ratio, on the other hand, has a numerator and denominator, but not necessarily that numerator is part of the denominator. So that is what differentiates ratio and rate, wherein ratio, numerator is not the part of denominator. In rate, numerator is a part of denominator. So in ratio, you will have two distinct entities. Say maybe if you have boys and girls, ratio of boys to ratio of girls, or if you have say RBCs and WBCs, so maybe ratio of RBCs to WBCs, white blood cells and red blood cells, right? So you can relate to entities and find out, the ratio of that. And we will talk more about the kind of ratios, in epidemiological and statistical jargon, what we use typically. Now, the proportion is out of denominator, say population at risk, what proportion is having the disease of our interest, the event of our interest. So that becomes the incidence proportion. Incidence, of course, is about the new disease. The prevalence talks about the overall disease, right? So somebody is new, somebody is old, all that combined gives you the prevalence, the total disease burden. Whereas incidence is something, a new entity in a disease free individual, right? So incidence is the proportion within the population at risk that actually develops the disease. Now it depends whether you are talking about an acute event, you're talking about a chronic event, whatsoever. You are measuring new case detection, and it is very simple metric, wherein we talk about the number of new cases of disease or injury during a specified period, and there is a size of population at the start of period, and there is a multiplier that exists, in that particular metric. Your multiplier can vary. It can be 100, it could be 1,000, it could be 10,000, it could be a lakh, depending upon how you want to express that particular metric. And it will also be contingent to how frequent that event is. Sometimes there are rare events, so the multipliers are basically more in order to express in absolute numbers, right? So for example, deaths that take place in pregnancy are not that common. So there we say the current mortality in the when we say the current mortality which is there in the mothers are say 140 per lakh live births. So out of 1 lakh live births, 130 or 140 fatalities are being encountered in the pregnancy period, right, in the mothers. So it's something which is not very common entity, and that's how we increase the multiplier and then we express. And this is basically seen a lot in the cohort studies as well, that we change the multipliers depending upon how much frequent that particular event is. Now, another very important aspect which you have to understand here is person time concept. And this is very important, particularly in cohort studies, wherein we calculate the occurrence of an event over a particular period of time. So when we are measuring the time, each person may contribute to a varying time period, which he or she is being followed up in a typical cohort study. Now, in that particular context, you have to understand that person time is used as a measure for accounting for what has been the length of follow up for a particular individual, right? So that is something which is very important to understand. Say, suppose there are 500 individuals, and each person sorry each person enters into the study at a different time point, and therefore is being followed up for different time period, considering that the enrollment of the study and the follow up can be variable and it may take some time. So suppose a person enters to the study in the first week of his initiation, and you follow that person for a continuous 5-year time frame before you actually are going to end the study. uh, in contrast to this, there's another person who enters after 1 year, and then he's just followed up for 4 years. and you're measuring whatsoever the events in those 4 years. So there's one person who is contributing to 5 year time, and another person is contributing 4 years of time. So there's a variable measurement follow-up period, and this is what is taken into account when we talk about person time. So you can actually calculate the person days, you can calculate the person years, and you can express that in the denominator, because the rate varies, because the denominator is going to vary, right? Because the rate is dependent on numerator and denominator, right? So incidence rate actually describes how quickly the disease occurs in the population. uh, this person time concept is of great importance, particularly in your follow-up studies, and wherein the individuals are enrolled and are followed for a long period of time. Uh, the range can be 0 to infinity. And the drawback is that the person time assumes that there is a probability of the disease within the entire study period is constant, and this may not be true always. Now, say in a COVID-19 pandemic situation, somebody who, we all witnessed the second wave, and we all know that, the transmission force was really high in the months of April and May. Starting from end of March, the transmission force of infection was very high. So the likelihood of getting the infection was really high during those particular months. Whereas if we compare the situation now, say in Delhi, the transmission force is not that high. So the rate of affected with a particular entity doesn't remain constant. There are certain other background characteristics that particular govern. So this also relates to the occurrence of an event, right? So that's the drawback. But then whatsoever demerits of a particular approaches, we go ahead with the situation, considering the limitation of that metric, and we utilize the best possible approach in handling and measuring the events. So how do we measure incidence rate? It's the number of new cases of disease or injury during specified period, and the divided by the total time that a person is being followed. And if suppose there are 1,000 individuals that are being followed, each person contributes say X person days. So and if there are 1,000, so I multiply their each individual person days and take into account the total person days that are going to be contributed, and that's how I calculate the overall denominator, and the numerator will remain the number of events that occur within that particular cohort of subjects that are being followed up. So this is a typical metric which is used in a cohort study over a period of time. And then the multiplier, uh, you can present in person days, you can also present the same metric in person months of follow up. You can also present the metric in terms of person years. So depending upon how much is the length of the follow up within your study, but all of these possible measurements and expressions exist when you are talking about the incidence rate. And in fact, whenever we study cumulative over a period of time, number of events that are taking place, and when we express in terms of denominators of such lengthy follow up, we calculate incidence density, and we refer this cumulative incidence rate as incidence density. So in a long-term follow-up study of morbidity, each study is being followed up for a longer period of time, and just to summarize, if suppose there is one person which is followed for 5 years without developing disease, is said to contribute 5% years of follow-up. And so suppose the end event is the disease, somebody who got the disease within 1 year was followed up to only 1 year, end of the 1 year, because he got the disease, right? And this is what is illustrated in this example. And let's read this example, which is quite an interesting example to illustrate, this entire concept of variable time of measurement. And what it basically says is investigators enrolled 2,100 women in a study and followed them annually for 4 years to determine the incidence rate of heart disease. Now, after 1 year, none had a new diagnosis of heart disease, but 100 had been lost to follow up. So we started with 2,100. The first year there has been 100 dropout, no occurrence of the disease of heart disease. After 2 years, one had a new diagnosis of heart disease, and another 99 had been lost to follow up. So there's one event that's taking place in the second year, that's the after the end of 2 years, and another 99 were dropped out. After 3 years, another 7 had new diagnosis of heart disease, and 793 had been lost to follow up. So we have a kind of this as an open dynamic cohort situation wherein there are people who are dying, so you have to basically account them, and they will only contribute to the follow-up period till particular that event. And somebody who has already got the heart disease wherein the event of interest has already occurred, so of course the follow-up ends in that particular study, because then they go in the numerator. After 4 years, another 8 new diagnoses with heart disease, and 392 more had been lost to follow-up. So suppose just to understand this situation, now there is an assumption, and the assumption is that the persons with new diagnosis of heart disease and those lost to follow-up, were disease free for half the year, and therefore they contribute only half year to the denominator. So if suppose that person had the event, or the person was lost to follow up, we will only include 6 months of their follow up overall in the denominator, as opposed to somebody who has not got the disease and who is still retained in the cohort, who is not lost to follow up, will contribute intact 12 months of study period follow up. So just to uh, uh, more exemplify and tell you exactly in very simplistic fashion what is the number of new cases of heart disease. So we have got 2 years one, so there is first year there is zero, end of 2 years there is one, 3 years there's another seven, so there is seven, and then after 4 years another eight. So in the end of 4 years we've got 16 such events of heart disease, so they all contribute to the numerator. And then we are calculating the denominator. So in the first year, no case, 100 lost to follow up, and the assumption was they will contribute only half a year. So half into 100 is like they contribute this much time, and 2,000 contribute to the entire year. They were total of 2,100. Then in the second year, we are being left with 1,900 people, and 99, were dropped out. One event has occurred, so 1,900 contribute to the full year, and one event that has occurred, so there is half 6 months of time, and another 99 basically contribute to 6 months of time. So that's how their contribution in term of time period as far as the person year is concerned. And then in the third year we say that there are another 7 that have got the disease, so half of that, and 793 have been lost to follow up, so they contribute half a year each. And we are left, after deducting all of these numbers, 1,100. And so is the calculation which is being done for the fourth year. So likewise, we calculate 6,400 person years of follow up. And if I am now reporting the incidence of heart disease in this particular population, so I'm reporting as 16 events of heart disease out of 6,400 person years, which basically gives me 0.0025 cases per person year, and that basically gives me 2.5 cases per thousand person year. So that's how in a typical study, which is longitudinal study, prospective study, I calculate and report the incidence density. So this is actually incidence density, which is nothing but cumulative incidence, which is reported in such a time metric. Okay. Now the next issue is about association.
Dr. Sumit, uh,
Yes.
request probably we can have this concept of person year once more, because there are many people who still are posting questions and it's a slightly difficult concept. So we can request please have it little bit more once more, please.
Okay. Sure. Sure. Sure.
Thank you. Thank you for your consideration. Thank you.
Yeah, so let me just explain this, once more. So the person here is, it's quite an important concept, particularly in longitudinal studies. And when we are talking about the longitudinal studies, say for example, there are 100 subjects, and we want to study them for 5 years. Now, when we want to study each of these 100 subjects for 5 years, uh, it may happen that they get the disease of our interest maybe in the first year, somebody may get it in the second year, somebody may get it in the third year, somebody may get it in the fourth year, somebody may get it in fifth year, or somebody may not get it, right? Now, our rule is that if a person gets the disease, he gets to the numerator and he's out of the denominator. Uh, and so he contributes to some portion of follow up, not the entire portion of follow up. Or it could also happen that somebody dies. And if somebody dies, he contributes some amount of follow up because the death has occurred. We are not following that person afterwards, so he contributes to some different amount of follow up period. There could also be a situation that the person migrates. He's lost to follow up, so he goes out of a place, and therefore he also contributes only some amount of time out of the 5 year follow up period that we intended for all of these 100 subjects for 5 year period of time. Now imagine if such a situation in a COVID setting. Let me just explain now. In a COVID setting, suppose there is a cohort study of 500 individuals. You are following them up. You have given the vaccination for COVID, and you're following them up for, say, 1 year period of time, each one of them after vaccination, till the end of 1 year. Now, somebody may get COVID maybe after 1 month, maybe after 2 months, maybe after 3 months. Somebody may not get till the 1 year, right? So if somebody gets COVID after 1 month or 2 months, so they contribute only the follow-up period as 2 months because they get into the numerator, and they will not be followed up for rest next 8 months or 10 months out of 12 months that we had. Whereas another individual who has not got COVID after vaccination is followed up for entire 12 months and will contribute to that particular period of follow-up. So each person in a cohort study is contributing a different time, of exposure or time for expression of outcome. So in that particular case, the measurement for that individual for follow-up period varies. Now, this is taken, an important consideration because the likelihood of the person getting the desired outcome may vary over a period of time depending upon the length of follow-up. So when you try to accumulate all that information for each individual, accounting for this variable length of follow-up, we try to summarize by calculating what is called as person time. And that person time can be expressed as person days, that can be expressed as person months, that can be expressed as person years. So of course, if suppose there is 1 year study, each person in a normal scenario will contribute 365 days. So if there are 100 individuals all followed up and all were there for 365 days. So 100 into 365% days are going to get. Now, because 100 into 365% days will not be there for all 100, some people may go out of the study at an earlier period of time. So we take into account their actual length of stay in the study. Was it say 200 days? Then for that individual we will count in denominator only 200 days. Likewise, for all 100 subjects we will calculate what is the percent days they are contributing to the study in terms of follow up, and then we will add all of this, and that will become actually the denominator. So that is percent days follow up cumulatively overall total for all the subjects, and the numerator will always remain be the incident cases or new cases that have occurred, right? So whatsoever that figure is, and when you will compute the incidence density, you will say the x number of events out of how many person days, okay, of follow up, right, in that particular cohort of individuals. So that is the concept of person time, and that actually gives you a good metric about that over a period of time, what is the rate of occurrence of a particular disease entity. Because that actually tells you, how much is the risk of getting that particular disease entity, or it could be a fall, it could be an injury, it could be acute event, it could be a chronic event, whatsoever that you are interested to report, right? So this is the person year or person time concept. This illustration actually gave it followed an assumption that how much contribution of a time particular period the person will account for. So we said that if the person dies, we'll out of an year we will assume that if you have the exact time of that person, you don't have to assume all of these things, right? I mean, this is just for illustration, such an assumption is done. But if you have the exact date of death, then you know actual how many days that person remained. If you know when the person actually dropped out from your study, you record that date, and you know the actual length of stay for that particular period. So then these assumptions may not be required. These assumptions may be only required when you do not know exactly, because not every time you'll be measuring the events in them. You will also study after a defined period of time. Then you will do kind of an interview, and then you will see measure their occurrences. You will record certain events. So sometimes things happen before that when you approach them for the data collection. So then these assumptions may be required when you don't know the exact date, right? So the person time concept is basically to calculate the total length of follow up that each individual is going to contribute in a particular longitudinal prospective follow-up study. You can also calculate in retrospective cohort studies and mixed cohort studies these follow-up periods. But these are very, very important when we talk about incidence rates, and incidence densities are being measured, expressing denominators as person days, as length of follow-up period each person is contributing in a study. We try to combine that, and then we express this as per person days, or per person month, or per person year. And you have a kind of a multiplier, whether it is 1,000, or it could be 10,000, it could be lakh, depending upon how you want to express it and what those features are. I hope this was clear, and this is an important thing, and I think there are some couple of exercises also being planned on this rant. So I see there is a raised hand. So can participants speak in this session? I'm not aware about that, but there is a. I mean, Dr. Ashwini, you can clarify if they
In
have.
fact, by side. I'm also answering all the queries.
Okay,
Maximum queries has been answered. There is one specific question till now that, sir, can you explain how we get 2000, 1900, 1100, and 700 in the denominator?
Okay, fine. So thanks for that particular question. So, what you have to see is that, see, there are 2,100, women who were enrolled in the study. Now, when we started, okay, and we started them following annually, right? Now, in the first year, we say 100 have been lost to follow up. So 2,100 minus 100 becomes 2,000. The rest 100 contributed half of a year. So 2,000 out of 2,100, 2,000 actually, contribute whole of year. Out of 100, because the 100 lost up, so we said we assume that they contribute only half of the year. So that's how it is there. So out of 2,100, we took into account 2,100, right? Now, when we are talking about the next, so we are now, we started with 2,100, we are left with 2,000 in the second year. When we are in the second year, they say there is another 99 that have been left, and one have got the event. So out of 2,000, if 100 are removed, you are left with 1,900, right? So in 1,900, you have 99 out, and one event occurred. So that's how this 1,900 is. So when we have these 1,900, out of this, if you see, 793 have been lost to follow up, and 7 had the new diagnosis of heart disease. So 793 plus 7 is 800. So 1,900 minus 800 becomes 1,100. So this is 793 contributing half an year, 7 events contributing half an year. So 1,900 minus 800 becomes 1,100, right? Now, out of these 1,100, the next last year they say you have 392 lost to follow up and 8 new diagnoses. So 392 plus 8 is 400. So 1,100 minus 400, it becomes 700. So that's how this number of 700 is there. I hope this answers the question now, right?
Thank you, Dr. Sumit. Please carry on. Thank you.
Okay, right.
They have loaded in the message. It's clear now, sir.
Okay, great, great, great. That's great. Nice. So now we have measures of association, and this is a very, very important fundamental concept that is used in epidemiologic analysis, and we very much have to measure the strength of association, and this is both in the case control studies, cohort studies, even in cross sectional studies, we can measure the strength of association, and we express these measures of association through some metrics which actually is going to quantify the relationship between the exposure and the disease. Now, largely, what you have to remember is that we talk about exposure and outcome relationship in most of the epidemiological studies, and we want to see whether this exposure is likely to lead to this particular outcome or not. So in that context, we are relating these two variables, and we want to understand their kind of association. Now there are two measures of association. There could be ratio measures and there could be difference measures. Now, the ratio measures are measures of association in which the relative differences between the groups are being compared, and this is very, very important, particularly for categorical outcomes, which is the issue of discussion today during this current session. And we most importantly, when we talk about the measure of association, we talk about odds ratio and relative risk or risk ratio. So these are the two, very, very important, odds ratio and the risk ratio, as two very, very important things. Now we will see one by one, these, entities, and they are usually described as to describe the measure of association. Now, risk ratio or relative risk is computed in cohort studies, in follow-up studies. Particularly, the example that I was citing just now was an example of a cohort study. So we talk about risk ratio. Now, it is defined as the ratio of the risk of disease in the exposed individuals to the risk of disease in unexposed individual. So there is a relative risk, and when we talk about the relative risk, it basically is the ratio of two risks. There is one absolute risk which is there in the numerator, and there is another absolute risk which is there in the denominator. Now, the absolute risk of disease among exposed individuals divided by the absolute risk of the disease among non-exposed individuals. So that is how we calculate. So it's a ratio of two absolute risk, and that's why it is called as relative risk or a risk ratio. Now let's see one example. So suppose we wanted to study the relationship between common mental health disorders, whether they are present or they are absent. So it's a categorical variable. There are two categories: presence of the disease or absence of the disease. We were interested to see the students with physical activity, those who were physically active, as compared to those students who were not physically active, I mean, who have higher occurrence of common mental health disorders. So this is a two by two table. Many of the epidemiologists, I mean, almost everyone, is fond of talking about these two by two tables. We have exposed and the diseased individuals, and the layout is this. So we write the disease here. We are interested in measuring common mental health disorders, presence or absence, and we basically lay out the exposure as physical activity. Say yes or no. So we have the total exposed individuals who are A plus B, and those who were not physically active, that means they were not exposed to this particular variable, so they are C plus D. Now we want to study the occurrence of common mental health disorders among the exposed and amongst the non-exposed individuals. So the incidence of common mental health disorders among students that were exposed to physical activity is A divided by among exposed, which is A plus B. And the students who basically were not physically active or who did not participate in physical activity, the total non-exposed group is C plus D, out of which the C out of which the C actually, had the common mental health disorders after a particular period of time. So there, the risk of, the common mental health disorders among non-exposed, non-physically active group is C divided by C plus D. So the relative risk is given by this metric. It's A divided by A plus B divided by C divided by C plus D. So it's the ratio of these two risks. It's like the risk of getting the disease, getting common mental health disorders when you are physically active, when the students, among those students who are physically active, as compared to the occurrence and the incidence of common mental health disorders among those who are not physically active. So that's what this relative risk is going to tell you. Now, another example, just to illustrate the same concept, suppose there's a cohort study, hypothetically, was measuring the incidence of breast cancer in women who did not take calcium supplements. So here we record their calcium supplementation status, and the data was collected from the sample who did not consume calcium supplement, and was found that 75 out of 100 participants who did not consume calcium developed breast cancer. Whereas those that consumed calcium, supplements, out of 100 such ladies, 25 got this cancer, and we need to compute, the relative risk. So the relative risk is going to be, the risk of breast cancer among those women who were not consuming. So this is 75 by 100. Then what is the risk of getting breast cancer among those women who were consuming calcium? So this is 25 by 100. So our relative risk is 75 by 100 divided by 25 by 100, which is actually 3. So what this basically means is that the risk of having breast cancer, developing breast cancer, is 3 times higher in women that were not consuming calcium supplements as compared to the risk of breast cancer among women that were consuming calcium supplements. So this is positive association because the number is on the positive side more than, 1. So that's something which is very, very important to understand. So when there is relative risk equal to 1, we say no association because the risk is equal. So in the exposed group and in the non-exposed group, when the relative risk is more than 1, it's basically positive association. And when the risk is relative risk is less than 1, it basically tells you there is a negative association. And this is basically protective. There's an inverse relationship, right? So you can have all these possible values of relative risk, and that's how we interpret in cohort studies, right? Now, another example just to illustrate the same thing. Now we are talking about rate. So lung cancer mortality rates, particularly for persons who were being followed up. And in this cohort, there were all kinds of mix of people. There were non-smokers. There were smokers who were doing currently smoking. Then there were smokers who quit smoking, and there was a variable period of their quitting, right? So ex-smokers and the years since quitting, and so less than 5 years, 5 to 9 years, 10 to 19 years, 20 plus years. And we recorded, because this was a follow-up study, how many individuals died due to lung cancer. So this is what was the event which was recorded. So in current smokers, 133 lung cancer deaths were recorded, and the entire, the rate per thousand person years was 1.30. So it is actually the rate. That means you have the denominator for person year follow up, and then they have taken into account this 133. So they are giving this absolute risk or a rate, absolute rate among the current smokers. Similarly, they have calculated the rates per thousand person years, and what they have done is the comparison is the non-smokers, because this is the non-exposed group, and these are different gradients of exposure. Okay, and when we have to calculate the relative risk, what we'll do, we'll basically divide 1.30 divided by 0.07. That is what is going to give us the excessive risk of dying from lung cancer when somebody is currently smoking as compared to non-smokers. And similarly, those who had the variable length of smoking presence, compared to them, what is the risk compared to non-smokers. And as you see, there's a declining trend which is happening over here, depending upon the years of quit smokers. And that's what we say, that the risk keeps on declining as the years of leaving smoking is compared to a non-smoker risk. So the lung cancer rate, was 18 times higher as the rate among non-smokers, and the smokers who can reduce their, kind of smoking, and also if they quit, and as the length proceeds, the risk keeps on declining. Okay. Now, the another very important concept apart from relative risk or risk ratio or rate ratio, we have odds ratio. Now, odds ratio can be calculated in a case control study, and I believe that the epidemiological study designs was covered on first day of this workshop. So you know that there are cases and there are controls, and we always go backward. It's a study which is done in a retrospect, and what we inquire is about the presence or absence of an exposure, and then we basically measure and compute odds ratio, which is the measure of strength of association. Now odds ratios can also be calculated in cohort studies. Odds ratios can also be calculated in cross sectional study, but typically case control study will always give you odds ratios. Now the question that we ask in such a situation is, what are the odds or probability that the disease will develop in an exposed person? Now, odds ratio is a ratio of two odds. And what is important to understand what odds is, odds is nothing but a probability of an event that occurs divided by the probability that event does not occur. So if the probability that the event occurs is p, the probability that the event doesn't occur is 1 minus p. So odds among exposed group could be the probability that the event occurs in the exposed group divided by the probability that the event does not occur in the exposed group. Similarly, we will calculate the odds in the non-exposed or unexposed group. So the probability that the outcome occurs in the non-exposed group, unexposed group divided by the probability that the event or outcome does not occur in the non-exposed group, and then we divide these two out. So odds of outcome in the exposed individuals compared to odds of outcome in unexposed individuals. It is this which actually, gives what is called as odds ratio. So just to give an example of this, suppose the prior research suggests that alcohol drinkers are associated with increased risk of lung cancer. A case control study was done to find whether this is true in a general Indian population. So we have the cases reported as lung cancer, and then there are no cancer cases, and the exposed group was exposed to alcohol drinking, and there was another group which was basically non-drinking, and we have this all of these cells recorded as A and B, C and D. Now let's see how odds ratio is basically calculated in a very simple fashion. So odds that an exposed person develop the disease. So who are all exposed? The exposed people are the alcohol drinkers. Now, so A is basically lung cancer divided by B, that the lung cancer does not occur, right? So probability of an event occurring divided by probability of the event not occurring in the exposed group. So A by B. Similarly, odds that an unexposed person, non-drinker, will develop lung cancer is probable. So the odds is the probability of lung cancer in this group divided by probability of no lung cancer in that group, that is C by D. So when you are dividing A by B divided by C by D, that's the ratio of two odds. So it is nothing but, sometimes some people also say this as a cross product ratio. It is AD by BC. So that's what odds ratio is. So, a group of researchers set out to find whether socioeconomic status is associated with risk of smoking. So, 286 individuals belonging to high socioeconomic status are smokers, and 1354 individuals belonging to low socioeconomic status were smokers. And they collected this primary data in a sample in Delhi and prepared a table like this. So there were smokers, from high socioeconomic status, low socioeconomic status, and this was not there. The smoking was not seen. So here the exposure is their socioeconomic status, and we are measuring the outcome in terms of smoking or not smoking. So the probability of smoking in the high socioeconomic status, so this divided by this, the probability of smoking, the odds of smoking in low socioeconomic status is this by this. So when we are talking about these two odds, and we divide them, that becomes basically odds ratio. So which is nothing but 286 divided by 868 divided by 1354 divided by 682, which is 0.17. So actually this is the odds of smoking in individuals belonging to high socioeconomic status is 0.17 times the odds of individuals from the low socioeconomic status. So that's how we basically talk about odds ratio. Now, as we did talk about the relative risk, the odds ratio, when it is equal to 1, that basically means that the two odds are equal, and so exposure does not affect the odds of the outcome. If the odds ratio is more than 1, the exposure is associated with the higher odds of the outcome, and when you have odds ratio less than 1, the exposure is associated with the lower odds of outcome. So that is what it is basically meant when we are talking about the interpretation of odds ratio. So you have relative risk, you have odds ratio. Odds ratio typically we calculate in a case control study. We have matched case control studies, unmatched case control studies. We have actually, we calculate odds ratios in this situation. You can also compute odds ratio in cohort studies, though we prefer relative risk or risk ratios computation in cohort studies. Now, then there is another measure which you have to know. As I mentioned that there are two types of measures of association. So one is the ratio measures, and the another is the difference measures. Now, in the difference measures, we can also actually calculate the absolute differences between the groups that are being compared. Now, main goal is often that we want to talk about an absolute reduction in the risk of an undesirable outcome. Now, when the outcome of interest is continuous, as we were talking in the beginning of the session, that there are continuous variables, the assessment of a mean absolute difference, between exposed and unexposed individuals may be an appropriate method for determination of association. So let's understand what absolute risk is. So it's the ratio of people. I've already talked about absolute risk, and I was mentioning the relative risk. And relative risk is nothing but the risk of two absolute risk, right? So absolute risk is the ratio of people who have a medical event compared to all the people who couldn't have an event. 26 out of 100 people will get dementia in their lifetime. The absolute risk is this 26 divided by 100, right? So whatsoever are the total people who get a particular event of interest, that actually tells you about the absolute risk. Usually it's given in the form of a percentage. Now, there's another entity which we are interested, and that's called as absolute risk reduction. Now, this absolute risk reduction is an important concept more so in interventional studies. Whenever you have a kind of an intervention, and what we want to see is that after people are exposed to a particular intervention, how much the risk reduces in getting a particular outcome, right? So you are going to just take the difference between the risk in the two groups, right? And that's what is going to give you the risk difference, right? So absolute risk reduction or the risk difference is the absolute difference in the outcomes between one group, usually in a randomized controlled clinical trial setting. It's going to be the comparison group, it's going to be the control group, and the group receiving treatment. It will always be compared, one where the new therapy or the experimental therapy is being administered. So the percentage tells you how much the risk of something happening decreases if a certain intervention happens. So the absolute risk reduction is the event rate that occurs in the control group minus the event rate that occurs in your experimental group. It could be any two groups that you are considering. You are actually, making the difference of the event rate in one group versus the event rate in the another group. So it's nothing but a simple difference in a particular outcome occurrence, who are exposed to different entities. So there are two groups. One is exposed to the intervention, another is not exposed to the intervention. You want to see over and above, what is the risk which is getting decreased as what is being seen in the control group, right? So 25% of people of depression medication have poor outcomes. 8% of people who receive medication and counseling, report bad outcomes. And so suppose, so without this combination, 25% reported bad outcomes. When you have these two combined together, only 8%. So the absolute risk reduction is 25 minus 8, which is 13%, which is nothing but a simple difference. So if 100 people were treated with both medication and counseling, 8 would report poor outcomes. That is what 8% is. So the difference is 13. So this is the extra benefit which is basically seen when you have the group. Now, with relation to this particular concept, we have another entity which is numbers needed to treat. And this has again a concept which is utilized in clinical trials. So the number needed to treat is the number of patients who need a specific treatment to prevent one additional bad outcome. So the number needed to treat specifies the treatment. I mean, you can mention whatsoever possible details of the treatment is, what is the duration, and also what is the adverse outcome being prevented. So, what you need to know is that the inverse of absolute risk reduction is actually numbers needed to treat. So, numbers needed to treat is 1 divided by absolute risk reduction. So, an ideal NNT would be 1, that is all the patients would get benefit. Now let's see some example. One example, what is numbers needed to treat? So if a drug reduces the risk of heart attack from 50% to 40%, so my absolute risk reduction is zero point 0.5 minus zero point 0.4, that is zero point 0.1. My numbers needed to treat is 1 inverse of absolute risk reduction. So it is like 1 by zero point 0.1, which is nothing but equal to 10. So what is the interpretation is, if a drug has an NNT of 10, it means you will have to treat at least 10 people with the drug to prevent one additional heart attack. So that is something that you have to remember, and that's what is in trials we basically talk about. As a general rule of thumb, an NNT of 5 or under for treating a symptomatic condition is usually considered to be acceptable, and in some cases, even the NNT is below 10. So NNT is a concept in the interventional studies, and there we basically explain this. So it's that's nothing but it's an inverse of absolute risk reduction. Now, when we describe absolute risk reduction, uh, it actually does not tell you how much they may benefit or a number of other key factors. So it's very important that whenever we talk about this, it has to be explained in terms of the context, and some things that you have to know. What defines success. So it's just not the number, but it's also important that there are certain other details which are being mentioned whenever you are trying to understand from LNT. So there is a complete cure, whether that difference is clinically significant, what that improvement basically means. If there is 5% improvement in pain, is that going to be worth? So we need to understand the complete entity of the outcomes that you are measuring and the differences that you are measuring whenever you are having this NNT. You also have to know that whenever the differences are being measured in interventional studies, it's very important to understand what your comparator arm is and what was that exposure. Was it through another therapy, which is an active intervention, or was it through a placebo wherein there was nothing which was being done? So no treatment is being done. So what is your comparison against which the treatment effect is being evaluated? How long the results are going to last? What is the average length of follow-up? What phase was the injury in case it was an injury? So the events and the outcomes are of acute nature or of chronic nature, subacute nature, and what is their severity index? So all of that basically is very, very important when we are going to talk about the numbers needed to treat. But just as a simple understanding, just remember it's an inverse of absolute risk reduction, and the absolute risk reduction is nothing but the difference in the two, the risk that we measure in two different groups. Now, switching over from there, and this was the basic background when we are talking about the measurements in terms of how we express frequencies and how we express the association measure. So we talked about incidence, prevalence, incidence, density. We talked about ratios. We talked about rates. We talked about odds ratios. We talked about relative risk or risk ratios. Now, moving a bit more in terms of statistical entities. Now, I think we did talk about the kinds of variables. There are exposure variables and there are outcome variables. So the exposure variables are also referred as independent variables. The outcome variables are also referred as dependent variables. Now, the dependent variables are of continuous, binary, or categorical. There are some time to events. We will not talk in all of these variables in this session, but largely we'll focus on binary or categorical variables. I'm also not focusing on regression. Regression is a technique to predict, the dependent variables when you know some of the independent variables, and there are different types. So we are not covering all of the concepts that are there in the analytics, but we'll focus something on the simple things which are there, right? So this is what, whenever the statistics or hypothesis testing is being applied to, you must understand that whenever hypothesis testing concept has to be utilized, we are actually trying to measure the relationship. We are trying to relate one variable with another variable. We are trying to relate one independent variable with the dependent variable, right? So we are trying to measure their kind of relationship in statistical terms and statistical measurements. uh, so all of this you have to consider. If you have two variables, what kind of variables are you dealing to? Do you have binary or categorical variables? And which basically means binary is nothing but a dichotomous variable which has got two entities, two categories. Say, for example, presence of a disease or an absence of a disease becomes a binary or a categorical variable with two categories, a dichotomous variable. You can also have three categories for that matter. So there also the statistical associations are being done, right? So now let us see some considerations and some approaches which in general you will have to think about. One is that what kind of dependent variable are you dealing with? So, is that variable continuous? Maybe a score of depression on a continuous scale, right? Or a pain, score in a scale of 0 to 10, or say cognitive abilities. So that's a continuous variable example. It could also be BMI being measured in numerics, right? It could be anything for that matter. Many of the biological parameters are actually continuous in nature. Then binary or categorical. I mean, we gave a lot of examples. Time to event. I mean, just to very briefly say what time to event basically means is that, say, generally in survival analysis, we say time to occurrence of an event. Say death is an event for that matter. So in a follow-up period, how much time that an individual took, for an outcome to develop, and if that outcome was death, so the time that is going to be taken up to death. So we are measuring the time. So it follows a different kind of statistical approach. Usually the Kaplan-Meier analysis, survival analysis, the hazard ratios computation, and things like that. Right. So we talk about what kind of dependent variable are we talking about. Then we talk about, are the observations independent or they are correlated, which basically means that are they going to be measured one time, or within the same set of persons you are having repeated measurements. So are these measurements correlated? If they are independent, you have different entities. If they are repeated, so suppose we do hemoglobin testing in individuals, before subjecting them to intervention, and then afterwards also. So it's a situation which is before and after. Whenever a situation is before and after, it becomes a paired situation. And then there are some other statistical approaches which are being applied in such a situation. And the third very important thing that you have to remember here is that we are talking about some assumptions, and the some assumptions are that the outcome is normally distributed. There is a linear relationship whenever we are talking about continuous. Now, when we are talking about binary, we say that all the categories have sufficient numbers, particularly more than five in each number, in each cell. And if the numbers are less than five, then we actually use Fisher exact test, and this is very important assumption for the chi-square test. And time to event, I mean, though we are not dealing that, but generally we have a proportional hazard distribution and that assumption. But I'll not go with that because that's not the issue that we are going to discuss. Now I'm going to take you through very fundamental background knowledge that you need to know when we are talking about categorical or binary variable analysis. And the most frequent test which is being applied is the chi-square test. So it's basically used for categorical variables. Both the dependent and the independent variables are categorical in nature, and then you are trying to relate them through hypothesis testing scenarios. So when the data is represented in frequency or percentages in each category, the assumption is that the subjects in each category are independent. And another very important thing that I mentioned here, that whenever all the cells and frequencies that we talk about here, they are more than equal to 5. Less than 5, we basically have to apply some corrections. It could be Yates correction, or it could also be, the Fisher exact test, which we have to apply. Okay. Now, so in classical textbooks you will find this explanation, but and again I'm just mentioning here just to illustrate this. But let me tell you that chi-square test, when you do really, these days we do all this analysis by softwares, and we get chi-square values and the p values, commonly reported. So we don't have to actually do this manually. This is just to illustrate this concept, but actually the softwares will tell you the exact values along with p values, and to tell that they are statistically significant or not, and whether you can reject the null hypothesis. So the chi-square statistic is basically given by this particular metric, wherein you are summing up all the cells, and the metric that is calculated is observed frequency minus the expected frequency, the whole square divided by the expected frequency. So in a 2 by 2 table, if there are 4 cells, you basically calculate for each cell this particular metric, and then you summate them, and that's how you calculate the chi-square statistic. So the symbols are, this is the symbol for chi-square test. You basically sum all the cells, this particular metric. The O stands for observed frequency in a particular cell, and E stands for an expected frequency, and you basically calculate this for each cell if the null hypothesis is true. Now let's see some example, very simple example and simple illustrations to understand. Say a group of 300 children, 180 boys, 120 girls, examined in grade 3 to see which was their dominant hand. And there was a contingency table which is prepared like this. So there were 120 girls, out of which 12 were left-handed and 108 were right-handed. Similarly, there were 180 boys, out of which 24 were left-handed and 156 were right-handed. Overall, there are 300, boys and girls or students there being examined in grade 3, out of which 36 use the left hand predominantly, 264 use the right hand. So this is a binary 2 into 2 categorical outcome situation, wherein we can construct 2 by 2 table. There are 4 cells here. This is cell, this is the second cell, third cell, and the fourth cell. So these are 4 cells. These are all observed frequencies in each of these cells. Okay. Now, because when we are talking about statistical testing, you also have to understand, we have kinds of hypothesis, which is null hypothesis and the alternate hypothesis. And when we talk about the null hypothesis, so null hypothesis means actually there is no difference between the two events in two groups. So the proportion of females who are left-handed, say this is my null hypothesis, that the proportion of females who are left-handed is equal to proportion of males who are left-handed. So there is no difference as in account to the genders, the two sex there. Okay. So the proportion of females who are left-handed is equal to the proportion of males who are left-handed. The alternate hypothesis is that the two proportions are not, same. They're not similar. So if H naught is true, so if H naught is true, then the proportion of left. I think somebody has to mute themselves. Yeah, thank you. So the alternate hypothesis is, that the two proportions are not similar. So if H naught is true, then the proportion of left-handed females should be same as the proportion of left-handed males. The two proportions above should be same as the proportion of left-handed people overall. So alternate hypothesis, as there is a difference in the proportion, whereas the null means there is no difference, the proportions are similar. Okay. So there is a chi-square statistic, which basically, follows such a chi-square distribution, and in a two by two table with two rows and two columns, the degrees of freedom becomes one. The degree of freedom is given as, the degrees, the number of cells that are free to vary, is basically only one, in a two by two table, which is given as number of rows minus one is number of columns minus one. Now, if the chi-square statistic is more than this chi-square, is basically the alpha chi-square, we basically reject null hypothesis. Uh, we reject the null hypothesis. Otherwise, we do not reject the null hypothesis. So we need to basically see the chi-square distribution against a particular degrees of freedom. What is the value which is expected chi-square? We compare the calculated chi-square with the expected, and that's how we calculate. Now this can be done in 2 by 2 table manually, though we don't do it, and therefore it's this concept is not very important to understand how we actually calculate the expected frequencies against the observed frequencies. So this is the overall proportion, which is x1 plus x2 divided by n1 plus n2, which is equal to x by n. So if you say x1 and x2, so actually, these are all the values which are there, and these are all, the ends that were there. So 12 plus 24, so 120 females. So N1 is 120. The 12 were left-handed, so that's basically 12. Then there were 180, males, so N2 is 180. 24 were, the left-handed. So 12 plus 24 is basically 36. So 36 out of 300 is 0.12. So based on all 300 children, the proportion of the left-handers is basically 0.12. That is basically 12%. So to obtain the expected frequency for left-handed females, multiply the average proportion of left-handed by the total number of females. So that is going to give you the expected frequency. So 0.12 multiplied by 120. Similarly, we have 0.12 multiplied by 180, which is basically 21.6 males to be left-handed. So this is the expected frequency. So which is 14.4 females to be left-handed. So this is the expected 14.4. This is what we calculated, 14.4, which is 0.12 multiplied by the 120. 120 were total females. Similarly, 180 were total males. So 0.12 multiplied by 180 is 21.6. So we basically calculate 21.6. So this minus this is this, and this minus this is this. That's how we get actually all you know the four frequencies which are expected frequencies. And then we actually calculate the test statistic. We have the observed frequency for each cell, we have the expected frequency for each cell. We can basically calculate f naught minus fe divided whole square divided by fe. So in this cell it's like 12 minus 14.4 whole square divided by 14.4, and that's how you calculate it. Similarly, for this cell you calculate 108 minus 105.6 divided by 105.6. For this cell you have 24 minus 21.6 whole square divided by 21.6 plus. So this cell you have 156, so 156 minus 158.4 whole square divided by 158.4. So you basically take the values of all this, and in this case it's calculated for you, which is 0.7576. You basically have 1 degrees of freedom. Chi-square alpha at p 0.05. You basically see that the expected, the metric of chi-square is 3.841. Now we got 0.7576, which is actually less than 3.841. So when it is actually less than, we actually cannot reject the null. So actually this is a non-significant result. So we conclude there is no sufficient evidence that the two proportions are different at alpha value of 0.05. So that's how we basically say. Now we also have another entity which is called as chi-square for trend. Now, this is very important when you have more than two categories, right? And this is also known as Cochrane Armitage test for trend. The test is appropriate actually for testing association between, a nominal variable with two levels, say infected and uninfected, and there is another variable which is an ordinal variable, say low, medium, and high. And if you see a consistent pattern or either on an increasing trend or a decreasing trend, you can actually compute and say that the trend is significantly different or not. Now let's so there is an ordinal variable here. So this is an ordinal variable. Now what this example is, the question is we want to answer is whether the proportion of patients with gingivitis increases or decreases among different groups that had different frequencies, increasing frequencies of mouth rinsing. So once a week, twice a week, thrice a week. So this is an ordinal variable. This is a categorical nominal variable, presence of gingivitis, yes or no. And that's how you basically have, different. Now we want to see whether increasing the rinsing frequency, does it have a decreasing gingivitis. So that is what is the trend that we are interested to know. And is this trend the difference between the groups, is it significant or not. So you basically calculate the mean values of all of these. Say for example, in the first group, we basically say 1 into 16, 2 into 9, and 3 into 2. So that's how, and divided by the total values, which are 27. So you calculate the mean for yes and the mean for no and the mean, and then you also get the standard deviation there. And again, let me tell you, all of this illustration, again, this can be just on a click of a command in the computer. So you actually do not have to understand how it is calculated, because the computer software is going to give you the values, and the p values are going to be reported, which you have to basically see, are they less than equal to zero point zero 0.05 or not. So similarly, so we get the value, and there is a trend metric which is there. You have the value of n1 and n2. This is n1 and this is n2. You basically calculate the chi-square, which were the mean values, and then you basically find out chi-square trend. You get the value which is calculated, and you compare it with the expected value against the chi-square distribution, and that's how, if you get a p-value, it's going to be signifying whether the trend is there or not. Now there's another situation, and what you need to understand, that there is a paired situation which is called as the McNemar test. So there's a McNemar chi-square test, and this situation is basically there in a paired situation. So something which is measured again and again. So there is a binary dependent variable, and there is a form of chi-square which is basically done within the same subject design. It is used whenever the same individuals are measured twice, matched on some variable, maybe say age, or participants are paired in some way, say basically twins or married couples, or responses on two measures are used if, on one measure and another measure, but on the same individuals. And at least there are five observations in each category. Just to exemplify, a researcher is testing a new medication and records if the drug worked yes or did not in 300 individuals. A table is set up with a count of individuals before and after being given the medication. So there is a condition which is measured with no and yes, and there is before and after. Now, what is very important to understand, when the subjects are same and there is before and after situation, you see the situation one and situation two, if they are both no, and there is a situation wherein before and after both the situation is yes. So the only points of disagreement is this, where in situation one, there was before, there was yes, but in the situation two, it becomes no. Or if you say the situation one, which is before, there was no, and in situation which is after situation two, it becomes yes. So actually, this B and C are the events which are going to actually contribute to the entire statistic here. So we say McNemar chi-square is actually given by this C minus B whole square divided by C plus B, and then you basically compare against the kind of a table chi-square values and see whether the values are significant or not. So just a message that I would like to give you is that the McNemar chi-square is used when you have a paired situation and you want to see before and after whether there is a difference or not. Now, very briefly, moving on to a very important thing, but that there are some test parameters, diagnostic test evaluation, and whenever we talk about the diagnostic test evaluation, we have some basic things that we define, and we basically try to compute the sensitivity, specificity, positive predictive value, and negative predictive value. Now, just the basics of this is sensitivity. We say the sensitivity is the ability to detect people who do have the disease, right? So that's very important. The ability of the test to detect, disease in those, sorry, in those individuals who do have the disease. The specificity is the ability to detect people who do not have the disease, and the positive predictive value is the likelihood that a person with positive test result actually has the disease, and the negative predictive value is the likelihood that a person with a negative test result truly does not have the disease. So we actually compute these statistics, and these are the basic statistics and the basic parameters that are very very important measures which are used for evaluating the diagnostic performance of a diagnostic test. Now, just to understand this, sensitivity basically, relates to the ability of the test to be sensitive to those who have the disease. So, if we make 2 by 2 table where disease is written at the top and the test results are written on one side, so you have positivity and negativity. So, the disease present, the disease absent, and the test results are positive or negative. And similarly, all the labels are true positive. So true positive basically means the disease is present and the test results also say they are present. So this is truly positive, right? Now the disease is not there, but the test says positive, it is false positive. When we have the disease is present, but the test is saying negative, it is basically false negative, right? It is false negative. And when the disease is not there, the test also says not there, it is true negative. Now what is measuring sensitivity? The sensitivity is measuring, true positives against true positives plus false negative, right? This is very important. Now, just to give you an example, when we say currently in COVID-19 situation, we have, we generally consider the gold standard as, RT-PCR test, reverse transcription polymerase chain reaction. We also got RAT test, which is rapid antigen test. The rapid antigen test basically has an advantage that it is point of care test and it gives you results within 20 to 30 minutes. Now, what is being said is it has low sensitivity. Now, what it basically means is that if there is a negative result, it may be a false negative. So actually, the person may be diseased, and that is the reason. If you get a negativity or a negative report on rat, you basically ask the person to get RT-PCR done for a confirmation and ruling out that he doesn't have the disease. So a test that has got low sensitivity, can have high false negativity. So that is very, very important, right? A test with a high sensitivity will have low false negativity. So that is what it basically means. Then when we talk about specificity, uh, uh, we are basically talking about that we are able to rule out the disease in the people with full accuracy. So the negative people, we rule out that there is no disease. So in the disease negative, we are talking about they are true negative, and we say that specificity is equal to true negative divided by true negative plus false positive. A test that has got low specificity, there could be high false positivity. Okay, so that's how it is. Then we talk about the positive predictive ability of the test, which basically means that if the test is positive, how sure are you that the person is true positive? So a test with a high positive predictive value, you have a high true positivity and a low false positivity. So the positive predictive value is equal to true positive divided by true positive plus false positive. So out of all positives that are given by the test, how many actually have truly the presence of disease? So that is true positive divided by true positive plus false positive. Similarly, we have negative predictive value, which is negative predictive ability of the test. So if there is a test result which is negative, we say, how sure are you about that there is no disease? So it's true negative divided by true negative plus false negative. So out of all test negatives, how many are truly negative? Now, the positive predictive abilities of the test are also determined by the prevalence and the background presence of the disease. So higher the prevalence, the predictive abilities also are higher when we talk about the disease. So when we talk about the diagnostic testing, before we subject the person to a diagnostic test, there is always a pre-test probability that the test is going to come positive or negative, and this is determined by the prevalence of the disease in a particular context. And then the parameters are the sensitivity and specificity of a particular test, and the post-test probability is given by your predictive abilities. Now, accounting for all of that, we have a very important consideration. We want to actually, reduce uncertainty about the disease diagnosis. We generally say that the pretest probability should be intermediate, ranging between 10 to 90%. We can have another concept which is called as likelihood ratios, which can be considered before ordering a particular test to determine the changes in the post test probability. So we have an entity in diagnostic test which is referred as likelihood ratios. And the likelihood ratios actually combine the sensitivity and specificity of a test with pretest probability of a disease in a specific patient, avoiding the need to perform statistical calculations based on the test characteristics and the prevalence data. So LR, likelihood ratio of a positive test, is given as sensitivity divided by 1 minus specificity, and a likelihood ratio of a negative test is 1 minus sensitivity divided by specificity. They provide a sense of how powerful a test is in influencing our pretest probability of the disease. The likelihood ratios may be positive, which are used when assessing the presence of disease when the test result is positive, and the negative likelihood ratio is used when excluding the disease with the negative test result. Now we can actually calculate all of this also for tests which are being done in sequences, which are done in parallel, and things like that. So briefly, these are some of the parameters which are there to define the evaluation, the validation for the diagnostic test, and we really report all of this. And sometimes when we are doing this evaluation, it could also be an evaluation of diagnostic questionnaires. So all of these are measures of validity which are being explained in your study group, so that the results can be implied when they are taken to scale for a larger scale. And that's how we get to know about the results, and how much weightage of the results are. So I think that was it. What we learned about the different aspects of categorical data analysis, ranging from simple measures of frequency, understanding rate ratios, understanding incidence and prevalence, and then moving on to measures of association, which were odds ratios, risk ratios, and then, the most common test which is applied for categorical data analysis remain the chi-square test. And there are a variety of chi-square tests available depending upon the situation. If it was a paired situation, we use McNemar chi-square. We basically use a chi-square for trend when we have a nominal and an ordinal variable and we are testing them. And What is important is that the cell frequency should be more than equal to 5. And then we also saw, the diagnostic test briefly. Now, usually the degree of freedom is, depending upon the number of rows and number of columns. Uh, the importance of degree of freedom is, when you are using these chi-square distributions, you will have to see what that degree of freedom is to find out the chi-square at a particular alpha value. So it is basically governed by number of rows and number of columns. If it is R into C, table, so usually it's given by the formula R minus 1 and C minus 1. So number of rows minus 1 and number of columns minus 1. It basically is important in context that when you're going to see the chi-square values from the distribution and you're matching with your calculated chi-square, then it is given. Otherwise, in these days when we have these computers and softwares and we get the automated results, after that we set the commands and give the commands, we get the values of p value. So in that context, we may not have much role to play by the calculations that I illustrated. They are more of theoretical understanding and just for illustration, so that people should understand how we approach these concepts.
We cannot calculate chi-square if we have only a single row and a two column. It is not at all advisable because 2 by 2 contingency table is not completed. We have to go for a two test of proportion in that case if there is sufficient sample size to test for two proportion. Jet test for two proportion. There was a question, Dr. Sumit, from in the group, that if there is a one row and two columns, so chi-square is basically can't be done. In fact, thank you very much for having illustrative talk and a very impressive and excellent talk. Almost all the questions we both of us have answered. There was one question that why the limit of incidence rate is 0 to infinity.
Yeah. So, yeah. So you know, of course, the incidence to infinity is uh, not exactly, but what you have to basically remember that the limit in that context, it has to be an absolute value, right? Now, infinity in sense that when you are not able to measure and approach it, then you may lose at infinity. But otherwise, in all the studies, we will give an absolute value which is always less than infinity. Yeah. So that is an absolute value which you have to indicate.
I tried to reply to one question, that why odds ratio for a case control study and why relative risk or risk ratio for a cohort study. So I responded in that way, that since the odds ratio in odds we go for a case control study and we go from outcome to exposure rather than exposure to outcome. So in a case control study, it is practically impossible to ascertain when that exposure occurred in that individual, because we are going retrospectively and there can be a recall bias, and hence in a backward fashion we can't get an exact estimate of the point of contact or the point of accurate development of an exposure. Whereas in a cohort study or a longitudinal cohort study or a prospective cohort study, since we are following both the arms, the cases, the exposure and the unexposed group, so we know that how many of them go to develop disease and how many of them do not go to develop disease. So that's why we can calculate risk ratio and relative risk in that situation. So I think that's we want to supplement something more than that, that can be done.
Yeah, thank you. I just want to say that we can calculate odds ratio in a cohort study also. What is being believed is that odds ratio and relative risk in a cohort study, are going to be similar. The relative risk we can only calculate in cohort studies. We can't calculate in case control studies, because there we are not talking about the incidence. The disease has already occurred in a case control study. So in that context, you will not be giving relative risk in a case control study, whereas odds ratio can be calculated in a cohort study. Both are almost similar when you apply those kind of values, and you find out. Um, uh, I mean, in regression, more concepts, we try to use odds ratios and we try to adjust for them. Uh, uh, but both have its own advantages. Uh, as a measure of risk, cohort studies are better over case control studies, and they generate a greater level of evidence. So that is why relative risk, has a higher weightage in terms that uh, as a measure of association, it connotes a higher degree of causality, because it can determine the temporality of events which cannot be given in a case control study. So I think those are some tidbits more, when we associate study design and the measure of association that we are trying to ascertain or determine.
Then there were a couple of questions upon the residual or linear assumption of into. I have already responded that linearity, normality, homodasticity, and normality all will be discussed by me on correlation and regression. We have a separate session for a complete day on I think it's on 21st. So we will be demonstrating that. But already, but I have tried to answer but what are all they? And because there was a question that is the linearity assumption associated with what type of variable? In fact, linearity assumption is associated with an independent variable as well as a dependent variable, because both should be linearly related to each other in a simple linear regression analysis. The normality, the assumption of normality is for the residuals when we have an observed value and we have a predicted model based value. So what is the difference? That should follow the normal distribution. Then the independence of record, so that all has been answered. It will be more discussed in detail in the session that we will take on correlation and regression. I have attempted to address all. If there are still any question that any participant would like to ask, they can unmute themselves and they can ask. If there are two variables when there is no correlation, we should not opt for correlation. We should go for a curvilinear relationship. It is not always possible that if we have a data on a continuous variable, they will be linearly related. But broadly, either they will be linearly related or they will be curvilinear related. It depends upon the nature of the distribution of the sample from which the sample and the population from which that sample has been taken. So the world is not linear. Everything is non-linear, and the world is abnormal, and we say everything is normal. So that's an irony that we are having in the world of science. Could there be any question else?
Sir, how do we calculate standard deviation in case of Cochrane-Armitage chi-square test?
There is a specific formula to calculate, and it depends upon the sample size. We have not planned, but specifically, if you need, then we will see and we will try to demonstrate it.
Thank you, sir.
Anybody else would like to ask something?
Sir,
How? Yeah.
I was going to read that how to estimate the missing data in categorical data analysis.
Uh, Missing data in categorical data analysis is missing data analysis is a separate session which we have planned on 23rd. So some part will be discussed. In fact, to deal with the categorical missing data is very risky, because it is not advisable to label the patient as absent or non-absent or disease or non-disease when we don't have information, and that has an element of risk of biasing the result in the 2 by 2 contingency table, and whatever measures of association we will be getting, they will be biased. Either we will be under reporting or we will be over reporting them. The best strategy is to get rid of that record and and prepare a revised contingency table, and give the measures of association based on a limited subset of a data, and then report that this data or this estimate of measure of association in categorical data has been derived by excluding few of the records because the information could not be elucidated from the data analysis or during the process of data collection. Hopefully that addresses the question.
Yes, sir, certainly. Thank you, sir.
Anybody else would like to ask something? We have replied to the question by answering, and we are hearing the barking of a dog. Yes, we can calculate missing values by the help of regression analysis. There is a separate section, a half day on missing value analysis on 23rd. I think that is not on 23rd, it is on 21st on longitudinal data analysis. I am trying to be fast so that Dr. Sumit would be tired little bit from speaking 2 hours, and I know that he is very busy. He has been assigned many important and very important duties in his working area. So that's why I am taking the liberty of saving his energy to some extent to meet up the upcoming challenges in the newer week. I have already suggested one book in the chat box. That book is sufficient for medical statistics and biostatistics.
Hello, sir.
Yeah.
Hello,
Yes, yes, please go
sir.
ahead.
In a case control design, in a case control design, if I want to say that it's a matched group, both the groups are matched group on the socio-demographical variables, which stat I should use? Chi-square is okay?
McNamara.
McNamara.
Yeah, I just want to say that, there is a difference in the analysis of an unmatched case control study and a matched case control study. In a matched case control study, as we reflected in the McNamara, if we appreciated, in the 2 by 2 table there, the events that are agreeing, before and after situation do not contribute to the analysis much. The events where disagreement is there from one situation to the another situation, they contribute to the analysis. So the variables that are being matched for, will not contribute much in the analysis. So I think what is important to really, as a take-home message take, is that the unmatched and matched case control analysis are different. So it's a matched situation. Whenever there is a paired situation, a matched situation, a related situation, the test of significance are different.
Sir. Thank you, sir.
So anybody else would like to ask anything more? We can go on and on, no problem. Me and Dr. Sumit has been, I think, doing many times these things. We are being privileged and honored to do that. So any question is still further? Anybody wants to ask any question, they can unmute them or they can type it in chat box. Okay, since there is no question, so let me once again express my sincere thanks and gratitude to Dr. Sumit for providing his valuable time to us, devoting valuable time to us, and taking a wonderful session here. And in fact, this from this day onward, from the last from today and the coming 4 days, they are purely statistical in nature. So that's why Dr. Sumit told that since he's focusing on a categorical data, so that's why he just mentioned very briefly about the continuous data. So that's why today's session was on categorical data and tomorrow's session will be on continuous data. Then the next will be on longitudinal data analysis, followed by correlation regression. So these 4 days are devoted exclusively to one session. For today was on categorical data, and the coming three on a combination of categorical as well as quantitative data analysis.
Okay, thanks a lot. Thanks everyone. And it was really a pleasure to be a part of this, workshop. I enjoyed the session, and I hope you will take the learnings, ahead. So all the best for coming next days within the workshop.
Thank you, Dr. Sumit. Thank you, and all the best. Take care. Take care of your good. Take care of your good health. Take care of yourself. Thank you. And we will bother you, and we will keep you bothering, and maybe some of the participants can also have a privilege and honor to take your guidance in this regard formally.
Yeah.
Thank you.
Always,
Thank you, sir.
always welcome.
Thank you. Thank you. Thank you. So that completes the first session of today. I know it would have been little heavy, but statistics is heavy, and it is going to be heavier and heavier as we move forward. So some glimpses would have been demonstrated today. So now it's already 5:09. We have one session more, which will be on practical session. So I have two announcements to make. First, download a fresh sheet from your web portal in the tab of materials. When you will click on the tab of materials, then you will get a table, and the last row, which will be the file name, will be CDA. That is an Excel file. That same file we will be using for practicing the session today, and that same file you will be using if you are able to complete today or after some day. That same file you will be submitting through your browser to us in the web portal for further evaluation. So that's one assignment. So we are taking a break of 10 minutes because for 5 minutes we are trying to play some video you all will be enjoying. Because yesterday there was a request that silence is boring, and therefore we wanted that the silence should not be boring. So that's why we have taken a chance to play some of the relevant videos for your people. And you, by the time you watch the video or listen to it, download the file, and then after 10 minutes we will be taking the session forward. So we will meet exactly at 5:20. By my laptop clock it is 5:10 p.m. So we will be getting back to, we have already guided many times to get the material tab. Please follow the instruction. You have to log in the specific to the login page. You will get a material on the top left hand corner. So we will be meeting
Thank
at
you very much
5:20
for
now.
considering request, sir.
Yeah.
Thank you very much for considering request.
Thank you. Thank you. Thank you. So we meet at 5:20 now.
Do you have the statistical results of the study completed?
Yes. Despite problems with the modeling due to multiple violations and having to uninstall and reinstall Enterprise died 5 times, we finally completed the analysis. The good news is that the p-value for the primary comparison is 0.004.
Great. So the likelihood that my findings are due to chance is 0.004.
Not really. That would be an incorrect interpretation.
Oh, okay then. I see. Well, you must mean that there is a 99.996% chance that there is a real difference between the study groups. Or, equivalently, there is a 0.4% chance that the null hypothesis is true, right?
No, that would also be an incorrect interpretation.
Are you serious?
Unfortunately, I'm very serious.
Well, in the recent Jones et al. Study they reported a p-value of only 0.03 for the same comparison, so at least I have found stronger evidence of the effect. Correct?
Not exactly. The study was much larger, so they probably had more evidence of an effect than in your study, even though your p-value is smaller. I really can't be sure without looking at the results.
But wait a tick. Their p-value is larger.
Yes, I know, but p-values are weird like that. You can't compare their magnitude unless the sample sizes are equal.
What good is that? It's rare that two studies have the same sample size. So, can you explain to me what a p-value of 0.004 actually means?
Yes. If one assumes that the distribution of values is identical in the two populations under study, usually referred to as the null hypothesis, then the p-value addresses the following question. What is the probability that the difference between randomly selected samples will be as large or larger than actually observed?
You're serious?
Yes, the p-value is the answer to that question, so a p-value of 0.004 can be interpreted as follows. If the null hypothesis of no difference between the treatment group and the usual care group is true, then less than 0.4% of all experiments of the size in your study would result in a difference between the groups as large as, or larger than was observed.
Yeah. Right. Well, the
Clinical importance.
I have had enough. Please go away now.
आपको भी नहीं बना पा रहा हूँ मैं। अच्छा, आपने रिकॉर्डिंग दबा, उसने रिकॉर्डिंग नहीं दबाई है शायद, क्या
पता नहीं सर।
सौम्या ने रिकॉर्डिंग नहीं दबाई है, इसका मतलब।
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable that measure is?
We always use
3 patients per group or in total?
yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A and control. And drug B alone.
Oh, how many groups are you analyzing altogether then?
My grant is due tomorrow. I just need to know if I can just use 3 patients per group.
Okay, well, you probably should have come to me earlier for help with this.
All I need you to do is tell me that 3 patients are okay. B in the target cell cytoplasm and the subsequent induction of apoptosis. All proteolytic events can be quantitated at the live single-cell level by flow cytometry and imaged by confocal microscopy.
I understand very little of what you just said. Maybe we should talk more about this.
I just need to know if 3 patients are enough. My grant is due tomorrow.
We will need to meet to better understand this, before we can determine the appropriate sample size.
I can put you on my grant for 0.5% FTE. You can design and analyze the data later.
Do you really think that is enough to do the work?
Well, it may be less, if it is awarded, and the budget is cut.
Please go away.
I have a study, and I need to know how many patients I...
Do you have the statistical results of the study completed?
Yes. Despite problems with the modeling due to multiple assumption violations, and having to uninstall and reinstall Enterprise Guide 5 times, we finally completed the analysis. The good news is that the p-value for the primary comparison is 0.004.
Great. So the likelihood that my findings are due to chance is 0.004.
Not really. That would be an incorrect interpretation.
Oh. Okay then. I see. Well, you must mean that there is a 99.996% chance that there is a real difference between the study groups. Or, equivalently, there is a 0.4% chance that the null hypothesis is true, right?
No, that would also be an incorrect interpretation.
Are you serious?
Unfortunately, I'm very serious.
Well, in the recent Jones et al. Study they reported a p-value of only 0.03 for the same comparison, so at least I have found stronger evidence of the effect. Correct?
Not exactly. The study was much larger, so they probably had more evidence of an effect than in your study, even though your p-value is smaller. I really can't be sure without looking at the results.
But wait a tick. Their p-value is larger.
Yes, I know, but p-values are weird like that. You can't compare their magnitude unless the sample sizes are equal.
What good is that? It's rare that 2 studies have the same sample size. So, Can you explain to me what a p-value of 0.004 actually means?
Yes. If one assumes that the distribution of values is identical in the two populations under study, usually referred to as the null hypothesis, then the p-value addresses the following question. What is the probability that the difference between randomly selected samples will be as large or larger than actually observed?
You're serious.
Yes, the p-value is the answer to that question, so a p-value of 0.004 can be interpreted as follows. If the null hypothesis of no difference between the treatment group and the usual care group is true, then less than 0.4% of all experiments of the size in your study would result in a difference between the groups as large as, or larger than was observed.
Yeah. Right. Well, the important thing is that the p-value is less than 0.05 and therefore is statistically significant. Cha-ching. That means publication.
Well, maybe. You see, the thing is that statistical significance and practical or clinical significance are not the same thing. Just because a result is statistically significant doesn't mean that it has any clinical importance.
I have had enough. Please go away now.
I have a study, and I need to know how many patients I need. I think I only need 3 patients.
Okay, what kind of study is it?
I'm doing a lab study. Can I just use 3 patients?
That depends. What are you trying to show?
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable that measure is?
We always use 3 patients. That is what we have published before.
3 patients per group or in total?
Yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A. And can
So welcome back. So I think all of you would have enjoyed both the videos. And can anybody tell me that today there is no app or software required for today's hands-on? It was being declared yesterday. Only Excel file. The same Excel file will be used for demonstrating the discussion. Uh, so can anybody summarize that? What one person can take the liberty of summarizing any one and then the other one? Please feel free to volunteer yourself. Or I may start now taking the name also. I may take now. Please respond.
What is the question, sir?
Question is that can anybody summarize the 2 videos, what they are trying to discuss and what is the message in that?
Sir, the message is that the biologists need to learn statistics before going to statistician.
And the vice versa is also necessary, I think. The biologist should also teach little bit of biology to statistician. Then only they will be able to understand the research hypothesis more clearly. So it's the process of bilateral learning. Agree or disagree?
Agree, sir.
Thank you.
Just as it was told on the first day, that we need to be the master of, cannot be master of everything, but we need to be the jack of all trades.
Yeah, what exactly I said that we should be knowing something about everything and we should be knowing everything about something. So that's the basic purpose. Yeah. So hopefully that everybody has now downloaded the recent categorical data analysis Excel file. It is a single page file for which You do not need to do any software. We will be totally demonstrating many, almost 80 to 85% of what Dr. Sumit has discussed today with the Excel, that how we can calculate different measures of association on Excel itself. While preparing this exercise, I thought that should I also explore and teach you people to calculate the 95% confidence interval, but that was becoming too long and it would not have been possible to do justice to the topic of measures of association. So to start with, so now I will be how the chronology goes is that uh, one of our organizational team member consists of Pratibha, who is also a statistician, and who will be the file is with her. She will start demonstrating it. She will also explain, and I will also explain. So anybody has any doubt, they can interrupt anything, anywhere. Feel free. They are about I think 7 to 8 exercise, small exercise. Uh, now somebody is again asking, sir, from where to download Excel file? We have already reiterated the same thing, that you need to download it by clicking on the material section of your tab. So if many people are able to download it, you all should be able to do. I do understand and take the cognizance of the fact that there might be different windows open in your CPU or in your computer, but do try that it is under the material tab. When you click on the left hand side material tab, you will get a small table. The third row consists of today date. The records appended in the 3 by 6 table is the third row consists of the today's date and also the file which is by the name CDA practice. So that's, I hope Hemant ji, you are able to get it now. Hemant ji, could you get it? Okay. Now it's over to it's a QD. It is not QDA. It is CDA, categorical data analysis file. So the file would, when you will open this file, this file will look something like this. Vikas Agrawal is saying that I cannot see it. Are you on your or on your browsing page, web page? Then can you share your screen? Vikas ji, please share your screen. I am trying to make you the host. Vikas ji, I am unable to share my screen. Yes, Ramya, you want to say something? Amit ji, can you please help Vikas ji? Amit ji has already given the URL in the chat box.
Sir, I have given the direct link of the page, and just
Yeah, sure.
he should be logged in user only. That
Yeah.
is the condition, and there is no other restrictions.
Okay. Okay. Yes, we are proceeding now. Now it's over to Pratibha to first of all in a minute explain that what is this exercise and then go on starting. Pratibha, we can't hear you.
Hello.
Yes, now we can hear you.
Hello, good
Please go
evening,
ahead.
sir. This exercise is totally based upon the categorical data analysis. There are 7 to 8 questions in which we discuss about the risk, ratio, sensitivity, and specificity, and false negativity, false positivity, and absolute measure of association and relative measure of association. Okay, sir.
Pratibha, be little slow and try to be little louder.
Okay,
If,
sir. There are 7 to 8 questions in which we discuss the person year figure also figure uh, and we will calculate the prevalence of asthma prevalence and incidence rate, and we will also use longitudinal cohort study for to investigating the association, risk ratio, relative risk difference, and odds ratio, and absolute measure of association, relative measure of association, sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy. And also we discuss about the chi-square test. Here we will do the practical question for chi-square test. Okay, sir.
Pratibha, just hold on. I have shared the file and I have attached it in the chat box. Hopefully that is now everybody is comfortable. Pratibha, somebody is saying that your voice is broken, so you need to be near to your audio system, please.
Sir, I am near to the audio system. Uh, so we can start the exercise so that everyone will get what we are going to do. Am I audible right now or not?
Little bit louder now, please.
Okay. So what I am saying is we are going to discuss the categorical data analysis. Okay, in which we discuss the chi-square test, absolute relative measure, and measure of association, relative risk, odds ratio. Can we start the exercise now? Hello.
Yes, go ahead.
Okay.
Just a minute, Pratibha. See, if we will get all these, we will keep on getting the request of every minute. We will not be able to get. I am telling it for the last time now that I have shared the file on the chat box to everyone. You all can download there and let us move. Yes, go ahead.
Okay, sir.
Valmiki, please mute yourself.
Okay, sir. In the first question, in a community, 10,000 individuals aged 50 to 60 with no cardiovascular event were followed up for a period of 5 years. After the end of 5 years, 200 individuals died due to heart attack. Calculate the cumulative incidence of death due to cardiovascular death during the period of 5 years. Express the figure in 100, 10,000, 10,000 and 1,000. Now we can calculate the prevalence. How can we calculate the instance? Can you please tell me if anybody can tell me the instance formula?
Ma'am, total incidence of death divided by total persons years followed, ma'am.
You can see, you are able to see the question. So tell me the number of disease,
Ma'am,
number of
numerator will
patients
be
who are suffering
200.
from heart attack. Yeah, that is 200, right?
And
And total individuals are?
denominator will be 10,000 into 5.
Okay. So, okay. This is your instance rate, right?
Yes, ma'am.
0.02.
Yeah, ma'am.
Okay. Next, what we have to do, we have to calculate it in rate in 100, right? Wait. That is equals to 0.02
into 100.
into
100.
yes. So wait. That is 2%. Right?
Pratibha, you can also explain in Excel the use of fx and where the formula and y to type equal to a little bit. Some may be a good user of Excel, some may be using not so frequently. So we can spend 1 or 2 minutes in explaining this.
Okay, sir. Is it okay, sir? Which shows
प्रतिभा, मैं ये कह रहा हूँ कि एक्सेल में जो फंक्शन डालने का तरीका है कुछ लोगों को आता होगा, कुछ लोगों को नहीं आता होगा। तो यहाँ पे कहाँ पे डाला जाता है फंक्शन fx के बगल में जो फंक्शन लिखने का तरीका है उसके बारे में बता दीजिए। Pratibha, are you not saying something?
no, sir. I'm not.
I think should we follow this modality that I say and then you do it? Will it be fine?
Okay, sir.
Because
Sure.
voice is not coming. That's the issue. Okay, so this is the first exercise on categorical data analysis. It is being given that in a community of 10,000 individuals aged 50 to 60, no cardiovascular event was followed up. Uh, with no cardiovascular event, they were followed for a period of 5 years. After the end of 5 years, 200 individuals died due to heart attack. Calculate the cumulative incidence of death due to cardiovascular death during the period of 5 years and express these figures in thousand, in 100,000 and 10,000. Whenever we give some function, now Pratibha, you fx, what Pratibha is doing, you will find in Excel that fx is written somewhere, fx is equal to, so this is the column where we write equal to. So whenever we write in this bar equal to, the function appears. So that is there. So when we click on this, we can create different functions, and when you click on or select a category on this dialog box, you can get statistical, trigonometric, arithmetic, different types of function. Okay, in this way. Yeah. So yeah, okay, you can close this window now, Pratibha. So she has typed in equal to 200 divided by the 10,000 value. She got 0.02. Now we have to express this rate in 100,000 and 10,000. So what we can do, we can write a function also that at the position. Now you can, Pratibha, write the function in the box of rate in 100, rate in 1,000 and rate in 10,000. Pratibha, don't write now rate. Just in the, I am saying that in the box type equal to and the function, that function. Because when they will be submitting this particular assignment, they are expected to use the formula so that we can see that they have inserted it accurately. You need not to insert function here. Cancel this. Equal to, you can type C30 C30 divided by C30 into 100. Enter. I think it is B.
Yeah, yes, sir, it
B1.
is B.
B3. So what we have done, why I am written B3, that B is the column, and 2 and this when this value 30 is 0.02 is situated at the 30th row. So that's the function. In the same way, now you repeat the same thing in rate in 1000 and rate in 10,000.
Sir, can I say something?
Yeah.
Even after equal also, we can directly put, means click on that cell also, means where it has written 0.02, sir. It will also come instead of writing.
It will because but what will happen when we will write, it is better that we are able to insert the function. That's why I am demonstrating it. That's the reason.
Okay, sir. Thank you, sir.
That's the reason. Because we want to see all these functions that the participants are able to insert in Excel, and that's why it will help us in evaluation. Because if someone will be right, even what you said is right, it is fine, but in the purpose of demonstrating this is that we are able to tell the participants that how we find the position of a entry in Excel. Somebody will be quite familiar, it might be something new to some people. Okay, now you do the same thing for this rate to express the rate in 1000. Okay. Now, can three people interpret these values 220 and 200? What does this mean?
So it means 2%, 20 per 1000, and 200 per 10,000.
Can you be a little louder? We can't hear you.
So it means that the death rate is 2%, or it is 20 per 10,000, or 200 per 10,000, 20,000 per 1,000.
Can we have a little bit more better explanation, better interpretation?
So I think 2 means.
Yes, please go ahead.
2 may die. Out of 1,000, 20 may affect for the disease.
Be specific for the question. Try to interpret on the basis of question. Yes, please, Pranshal. Others can mute themselves, please, if other participants are participating, please.
So these scores effectively mean the same thing.
Yeah.
So when we are considering a group of 100, 2 people are going to die of heart attack in 5 years, are likely to die of heart attack in 5 years. And when we are considering a group of 1000, the number of people who are susceptible is 20. Similarly for 10,000. Is that fine, sir?
Yes, perfect. So that is there, that when we are expressing 2 out of 100, 20 out of 1000, and 200 out of 10,000 are probably going to have experience mortality if they are followed for a period of 5 years due to heart attack. That's the complete interpretation. Everybody has understood it. Can we move forward? How many of you are able to do this exercise? Just type yes in the chat box.
Yes, sir. Yes, sir. Yes, sir.
Please go on. Yes. I want to see yes equivalent to all cumulative number of peoples minus the organizers. Good. Keep on. Good. So we move forward. So we move ahead now. Pratibha, can you move ahead? This exercise is also the same. The only difference is the incidence and the prevalence. The first one was based upon the incidence, whereas this one is based upon prevalence. So we are leaving this exercise, we can move to exercise 3 now. Pratibha, you can delete the, yes, sure. You followed what I'm trying to ask. Good. So this exercise, you can carry on, Pratibha, you can do. In this exercise 3, it says that in a longitudinal cohort study to investigate the association between a liver cancer and alcohol use, following values were made. So what was it is saying that the study design is longitudinal cohort and the exposure is alcohol use and the outcome is liver cancer. So we have a 2 by 2 contingency table consisting of 4 entries, and we are having 40 individuals of liver cancer who used alcohol, 40 individuals who were non-alcoholic users but they developed liver cancer. In the similarly 10,000 and 60,000 are their numbers in for those who do not develop disease. So what Pratibha is now trying to say, he's creating the total of both she's calculating total of 4 things: total of first row, total of second row, total of first column, and total of second column. So again, she is giving you the demonstrating you the function, that what this function means, and she is also writing what does A, B, C, D, the general formula which Dr. Sumit demonstrated you people, that how to calculate different types of how to calculate relative risk ratio, odds ratio. So she is also tagging those values. Sir, you can increase the width of the cell where hash 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 is coming, then you will find the values. Because the values are large, they are trimmed. Values are there, they are not appearing as they should be. Okay, can we move forward? Anybody? Can we move forward?
Sir,
Yeah.
When we are putting A, B, C, D in that number, it is changing. The total has changed. Actually, means the formula is not working, sir.
Formula is working because you can see uh, uh, it is 40 plus 40 is 80. This is this. I think the formula is working.
For me, actually, when formula is working, sir, when I'm putting ABCD, it is changing. It's okay, sir. I'll do it, sir. I'll do it. Thank you, sir.
Sure. Thank you.
Before
In
putting
ABCD
ABCD, you
along
have
with
to
that,
calculate the value, then place the only value. Then after quote the ABCD.
Okay. Anybody can volunteer to solve this one? Khurana ji?
yes sir.
Yeah. We can't hear.
I'm just trying to solve it, sir.
We can't hear.
Sorry, sir. It will take me time, sir.
See, now what Pratibha is trying to do, little confusing, trying to understand. What Pratibha is doing is that she is converting those values into numbers by writing the alphabets. You can write also, you can not write also, but just for the purpose of demonstration, she's trying to be a little bit clear on making the formulas clear.
Sir, is it 0.04?
I think so. So we are demonstrating this for this one exercise. For others, we will be not writing A, B, C, D and other thing. So now Pratibha is going to calculate the risk of liver cancer among alcohol users. So what risk of liver means, what is the probability of developing liver cancer on the basis of this information among those individuals who are alcoholic users. So for this, we know that probability, we need two things. We need a numerator and we need denominator. So what is the risk? This will be 40 divided by 10040. Pratibha, please type the formula. Don't write risk equal to the function. Yes, by clicking. The somebody advised to we can click and we can get it done. It will not. I think you will have to remove those values. Then only the formula will work.
Yes.
Yes, somebody want to say something? Somebody wants to say something?
If you include alphabets, then it will not consider into
Yeah.
the formula.
Yeah. Yes, among non-alcohol users, it is 40 divided by 60040. Yeah. Go on calculating for the next among the non-alcoholic. So she's again writing the function D78 divided by that. So she's just clicking at the cell where the values are there. Okay. And now the difference is just right. Hitesh has written correctly. You can type the cell position, that becomes this. So we get the risk difference. That is what is the risk difference. So that means if you multiply 0.00332 by 100, that means 0.3% risk is high, is more in the those individuals, those who are suffering, those who are alcoholic users, they are getting liver cancer. Then the number, calculate the risk ratio now. So risk ratio, what will be the risk ratio?
Risk of liver cancer in alcoholic divided by risk of cancer in non-alcoholic.
Yes, yes. Yes, it is 5.98. In fact, Pratibha, you can just, for this calculating the risk ratio, already you have calculated two probabilities. So you can insert the function there from the first block divided by the second block, because already you have calculated. So you need not to go to your contingency table. So this one, yeah, yes. So what is the interpretation? That those individuals who are using alcohol, they have got almost 6 times higher likelihood of developing liver cancer. Somebody requested to repeat the process. So Pratibha, can you repeat by saying also? Is it fine? Can we move forward?
Yes, sir.
No,
So can you
she was not
explain?
speaking. She was not speaking. Okay.
So can you explain the interpretation of the risk difference?
Risk difference is 0.00398 and 0.00367. So the probability or the risk of liver cancer in alcohol users is this much. Among non-alcoholic users is this much. So difference means how much risk is more in one group as compared to other group. So you can see here that since this is a hypothetical data, so probably the risk is coming it is coming less in case of non-alcohol. It is coming more. It is fine. In fact, it is coming more in alcohol users, 0.00398. It is coming less in non-alcoholic users. And since if you take the difference, you minus, you subtract 0.00067 from 0.00398. That means that extra risk or the more risk is there. The risk is more by by equal to the difference of these two values of liver cancer among the alcohol users. That's the risk difference.
Okay, sir. Thank you, sir.
Excuse me, sir, I have a question.
Yeah.
So may I ask a question?
Yeah.
Sir, in what case we use risk difference and what case risk ratio?
When we want to give the absolute measure, that is
Okay.
absolute, which is, then we use the difference. And when we got need to give the relative, something in relation to other, then we give the rate ratio or risk ratio or relative risk or odds ratio. That's the difference.
Okay, sir. So which is, sir, more scientific measure?
All the measures are scientific measure. It depends upon the interpretation and the way in which we want to convey the results to have some meaningful conclusion.
Okay, okay. Thank you, sir.
Hello,
Can we?
sir.
Yeah.
Sir, I would like to see the calculation of risk ratio. I have missed out that step. Last
Uh,
one. Risk
uh,
ratio.
which one?
Last column.
Okay,
Yeah, that one. Yeah.
Pratibha, repeat once more. And you can
Yeah. If
speak
she just
also.
clicks,
Try to.
yeah. If she can just click, I can see the formula, sir.
Yeah,
That is
equal
also
to.
fine for me. Yeah. Okay. Okay, fine. Thank you.
That is clear now, right?
Yes, yes. Thank you.
Somebody asked that do we need to write interpretation in the box also? Yes, that's the purpose of interpretation, because calculation is mathematical in nature. But what conclusion we are drawing, what does those values mean? That's why this exercise has been, this is practice and exercise both, so that you can follow us also. And if there is some problem, if it doesn't complete, we can go forward and you can submit it later. Yogita, you have a question?
Yes, sir.
Yeah.
Sir, can you please explain the concept of number needed to treat?
When it will come, then we will in fact I am calculating how one number needed to trace mean it is the inverse of relative risk ratio. So it means that how many patients are needed to be treated by a particular intervention or a particular drug or for a particular therapeutic regimen, so that one additional individual is being saved from developing that disease. That's the
Okay, okay.
interpretation.
Okay, sir.
मतलब उसका हिंदी में मतलब होता है कम
सर
से कम
समझ
कितने लोगों
मतलब
को
कौन
कम आप
मतलब कौन
या
सर मेरा एक बार सुन लीजिए अगर कुछ
हाँ
सर जो हमें समझ में आया उसका मतलब ये है कि अगर हम कोई इंटरवेंशन किसी स्टडी में कर रहे हैं तो कैसे कितने ऐसे रेशियो है ऐसे लोगों का जिनको हम इंटरवेंशन करके प्रोटेक्ट कर सकते थे किसी डिजीज से।
नहीं, इसका मतलब ये हो रहा है कि हमको कम से कम कितने लोगों को ट्रीटमेंट देना पड़ेगा ताकि किसी भी एक एडिशनल इंडिविजुअल में इवेंट होने को हम कम कर सकें।
अच्छा ओके, तो जैसे ये एग्जांपल है ब्रेस्ट फीडिंग का और डायरिया का।
अभी हम
तो,
वहां पे पहुंचे नहीं है योगिता अभी।
हाँ सर ओके।
Let me reach there.
Sir, I have one doubt.
Yeah.
In the risk of liver cancer among alcohol users,
yeah.
It's getting rounded up, sir, in my screen 0.004.
You can increase the decimal point.
Okay, okay, sir. Yes,
okay.
sir.
Can we move ahead?
For other things, I'm getting the
because your column width would be less and there are 2 or 3 zeros after decimal. That's why it is truncating. You will have to increase the width of the column.
Okay, sir. Thank
Okay. Can we move ahead, please? Yes, move ahead. Now, this exercise 4 is on self-learning disorder, SLD, present yes or no, and the family history. So in a family, whether there is any family history of SLD or not. So technically speaking, that becomes this is a, we want to demonstrate that how to calculate the odds ratio in this case. So what is the odds of developing SLD among the family history of those who have the family history? In the same way, we calculate the odds of SLD among families who doesn't have the family history, and we take the ratio of both the things, that becomes odds ratio. So the values of which A, B, C, D was being said, 81 is the value of A, 995 is the value of B, C is 57, and D is 867. So Pratibha, now you can go on and demonstrate this calculation.
Okay. Sir, may I continue or need to wait?
You can explain what you are doing, Pratibha.
So what I did, I am adding these two values, 81 plus 995, which is equals to 1076, and the family history with no SLD, 57 plus 867, which is 924. I used a formula which is equals to sum of these two values, and there is another total 138 and 1862.
Pratibha, you delete the function of sum here.
Okay.
I am trying to demonstrate that how we can directly calculate the sum without using the function. Delete 138, 1076, 924, and 2000.
Okay, sir. Okay.
And click on that summation symbol to get the sum. So what we are trying to calculate here, the same thing, two values, sum of नहीं प्रतिभा, I am trying to say don't, आप इसको डिलीट करो, ये सारी वैल्यूज को डिलीट करो एक बार.
Okay, sir.
और विंडो को बड़ा करके आप ये कैसे सम करते हैं सिंबल से बता दो. मतलब आपको वो टैब शो करना पड़ेगा, जो ऑटो हिडन है उसको शो करना पड़ेगा. या प्रतिभा,
Yes, sir.
मैं ये कह रहा हूँ 81 और 57 को सेलेक्ट करके समेशन कैसे समेशन को क्लिक करके आता है वो बता दो। 995 को और 867 को 7 को सेलेक्ट करके नीचे वाले उस पे कैसे आएगा, 81 और 995 ऐड करके कैसे आएगा, 57 867 ऐड करके कैसे आएगा। एक इंसर्ट रो है तो फंक्शन अगर डायरेक्टली करोगे तो वो नहीं काम करेगा।
Yes.
Prativa, I am sharing my screen. Stop sharing. Is my screen visible to is my screen available to all of you?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, yes.
So
Yes,
what I
sir,
am
it's
trying to
fine.
do is I am seeing this I am trying to solve this one. What I am doing is I am selecting this 81 and 995 by pressing shift and right arrow key, and where you find this total and I click here, that summation symbol, you get the total like this. In the same way I select for 57 and 867 and I click on this function, I get the second column total. I select 81 and 57 and I click on this, I get 138. In the same way I select this, I get this summation and I get this as the total. So what I am getting 1076 as the total individuals who had a family history, 924 as total individual who doesn't have the family history, 138 individuals are those who reported SLD, of which 81 had a family history and 57 doesn't had. And for SLD no column, which is 101,862 individual doesn't have an SLD, and we had 995 and 867. So when you sum up 138 plus 1862, that becomes 2000, and 1076924 becomes 2000. So the contingency table is distributed in such a way that you total both the columns, or you both total both the rows, that becomes the grand total. Can I move forward now? Yeah, is it fine? Can I move forward?
Yes, yes.
Yes. Now what we want to calculate the odds of SLD among family history, among, that means odds of developing SLD among individuals who had a history of family history of SLD. So I am writing here formula equal to, and I am clicking this at 81 divided by 995. So A divided by G, that means the what is the odds of developing SLD among individuals who had a family history. In the same way, I will do the odds of those individuals who don't have the family history. So that becomes 57 divided by 867. Now, why I am typing the cell position, let me explain. If I write here, 81 divided by 995, I will get the same value. But if well, you can calculate and give the value, but when I
Sir,
write
why 995? Sir, why 995? Why not
odds
the total?
odds of developing the odds, yeah, it is, yeah, 81 divided by 1076. Thank you for correcting me. So this, no, I think don't confuse me.
Sir,
It is fine. It
it
is
will
fine.
be 81 divided by 995
Yes,
because we
yes,
are
yes.
calculating odds, not the risk.
Yeah, not relative risk, we are calculating the odds. So this is, so when I put my put to the cell position, what happens, even now if I change these values, if I change this from 32 to, say, if I calculate and I give it to 345, the values automatically gets updated in the function. That's the purpose of giving the function. So that's why now you calculate in the same way the odds of developing SLD among those individuals who didn't have the family history. So this divided by this. So I am giving the cell positions only, and I get the odds in both the groups. Now we have to calculate the odds ratio. So it is again this function, the first odds divided by the second odds, divided by the second odds. This gives you the value of 1.23. Can anybody interpret what does 1.23 mean?
So the answer is the odds of developing SLD among those with family history is 1.23 times than those without the family history.
Yes. Can you tell me in percentage?
There are 1.2 there are 1.23 times.
1.23 is fine. Now I'm asking the second question. Can
Okay.
we express this in percentage now? What is the percent more? Percent
We
risk?
can
10
you have
10.23. 10.23%.
Yes, 23%,
23 into
24%.
yeah.
Okay, because it is 1.23. Had this value been 2.23, what would have been the percentage of more?
123%.
Yes, correct. So that is how we calculate the odds ratio in case of a case control study. Is it clear? Can I move forward?
So, I'm so sorry, can you please explain how did that come? 23 and.
What you are asking, Shanimar?
सर दैट 1.23 टाइम्स है ना, तो परसेंट में कितना होगा सर, एक बार वो रिपीट कर दीजिएगा.
1.23 है तो 1 से कितना ज्यादा है? 23
जी.
तो दैट मींस दैट इज 23%. अगर 2.23 होता तो मतलब वो 100 से भी ज्यादा हो रहा है, तो 2.223 माइनस 100 दैट बिकम्स दिस, और 1.23 माइनस 1 जो भी इंटू 100 कर लीजिए तो 23% हो गया.
ओके सर, तो वट एवर इट इज अबव 1 है ना.
इट इज जरूरी नहीं होता है कि वो हमेशा अबव 1 ही आएगा, यहाँ पे 1 से ज्यादा आ रहा है.
So 1.23 times means 23%. So actually I could
No,
understand.
1.23 means 1.23 times more, and 23% means when we are expressing this ratio in percentage, then that is 23% more risk. That's the different interpretation of the same value.
Okay, and if it was 2.23 फिर क्या होता सर?
बताया तो 123% ज्यादा या 2.23 टाइम्स ज्यादा, मतलब 2 गुना ज्यादा लेकिन 3 गुना से कम.
Okay, sir. Thanks.
Can I move forward?
Yes, sir.
Or others to also tell me?
Yes, sir. No problem.
Sir. Yes, sir.
Yeah. Now we are calculating. This is little tricky question now. Now in this question, everything is there in fact. So what is there in this that in a community rural, Asha nurse was interested in studying the association of esclerotic. So I'm cutting it short. That there is a community. Asha nurse was giving counseling to women in postpartum period for what are the advantages of having a exclusive breastfeeding. So exclusive breastfeeding counseling as well as advice on that for was given, and the study groups were divided into two groups. There was a group in which there was no counseling, and for other there was counseling for exclusive breastfeeding. And what interested was there that 100 in the whether what was it did any infant among infants diarrhea was reported or not. So this is the contingency table of 100, 50, 50 and 25, and we have period of years of observation. So we have years of observation also for those individuals. Now for this we are calculating everything. We are calculating absolute measure of association. We are calculating also the relative measures of association. Now can anybody tell me that what will be the how do we can calculate the risk of diarrhea in the group of where no counseling for breastfeeding was given, but I am interested in measuring the absolute measure of association? How to go for this? Anybody can volunteer themselves?
100 divided by 150.
100 divided by 150 or 100 divided by 300?
No, 150. Because
Why?
that's the year of observation.
Yeah, so we are getting person years of observation. Can't we calculate 100 divided by 300? I am just debating. What you are saying is relative measure of association. 100 divided by 100 plus 50 is 150. That will
Yeah.
be the relative measure, not the absolute measure.
Okay.
Okay. So that
Okay.
becomes this position 100 divided by 350. We get the risk of diarrhea in the group where no counseling for breastfeeding was given. And now
Yeah.
we calculate in the same way. I will request to please mute once spoken, and then this and this by this. And now we can calculate the risk difference by putting this position minus this position. And if I want to calculate the number needed to treat, which Yogita was asking, it is this. I have been little fast. I am repeating. In this case, we have a contingency table of diarrhea and status of counseling for breastfeeding. We have person years of observation given. So when we are talking of absolute measures of association, we have to take into account the person years of observation. So when we have to calculate the risk of diarrhea in the group where no counseling for breastfeeding was given, we just type the formula. This where 100 is written divided by 300. So 100 is written at cell position F130 and at cell position J 130 300 is written. So I divide 100 by 300. I get 0.33. Now what does 0.33 means? Can anybody tell me what does 3.33 means? Hello?
So can we interpret this as there are 33% of risk in
Yes, right. Right. Good. Thank you. So there is 33% risk of developing diarrhea among those women who were being not given counseling for breastfeeding. That means if 100 there if in this community if there are 100 individuals, 100 women who have not been given counseling, then their chances are that among 33 women or children will report diarrhea. That is the problem. In the same way, when we go for the other group, counseling for no breastfeeding, where counseling for breastfeeding was given, that is 0.2. Now we subtract. So the absolute risk is, that means calculate the risk difference, or the absolute risk difference is 0.33 minus 0.2, that is 0.13. Now what does 0.13 means? Anybody?
Counseling reduces the risk by 13% of
Yes, the
developing diabetes.
counseling helps us to reduce the risk by 13%. That's, and now what will be the number needed to treat? Number needed to treat will be 1 divided by the relative by the risk. That is the I think in fact based on risk difference it is 7.5. We can also calculate on the based of the relative risk also, that is also possible. So for on the basis of risk difference it is 7.5. And now one of the question which was been asked by Yogita ji, it was that what does 7.5 means? Now 7.5 means that if we have to prevent reporting of one case of diarrhea in this community among those individuals or among those women who were not given counseling for breastfeeding, we need to counsel at least
7 women.
at least eight women for the for exclusive breastfeeding. Is this fine now, Yogita?
यस सर अगर हम केवल रिस्क की बात करें, रिस्क डिफरेंस के ऊपर ना निकालें तो वो सिंगल क्लस्टर के ऊपर बात करेगा, और अगर डिफरेंस के ऊपर निकाले तो
देखिए, I am telling you what's the use of this.
हाँ हाँ सर
Now suppose there is a person who is illiterate, who is belonging to a lower socioeconomic status, and you say to him or her कि we need to treat 8 individuals to prevent single case of your baby. It will not hold a meaning, any meaning to that. So
Yes.
these measures, number needed to treat, relative risk, these all are measures of association which are used in different scientific contexts to explain that what is there. That's the use.
हाँ सर, वो हम समझ गए सर।
Yeah.
एक क्वेश्चन और है,
हाँ.
वो ये है कि अगर हम किसी जैसे हमने अभी क्लस्टर वाइज रिस्क निकाला कि नॉन काउंसल्ड फीमेल में कितना रिस्क है बच्चों में डायरिया होने का, और काउंसल्ड में कितना रिस्क है डायरिया होने का, तो अब हम यहाँ पर ये जो एनएनटी निकाल रहे हैं, ये हम निकाल रहे हैं रिस्क के डिफरेंस के ऊपर। तो सर अगर हम रिस्क के डिफरेंस के ऊपर निकाल रहे हैं तो ये 7.5 हो रहा है, लेकिन अगर हम सिंगल क्लस्टर के ऊपर निकालें, मतलब कि अगर केवल नॉट काउंसल्ड फीमेल के लिए डायरिया का नंबर नीडेड टू ट्रीट निकालें तो उसका
नहीं, एक सेकेंड, आप सिंगल वी विल द कैलकुलेशन ऑफ एनी मेजर ऑन सिंगल ग्रुप और अ सिंगल एंटिटी और अ सिंगल क्लस्टर इज एरोनियस इन नेचर ना. Without any comparison, there is no mean to say. By in that example, if you have only the odds of developing say lung cancer or smoking cancer in one group, that doesn't make any sense. You need to have a comparative arm. तो इसलिए किसी भी बिना किसी comparative, without any comparative arm, it doesn't make any sense to go for this.
Okay sir, thank you so much.
So since there are many questions in the chat and I am demonstrating, it is not possible to me do both the things simultaneously. If anybody wants to ask till this point anything specific, I can answer them.
Sir, can we use NNT for calculating sample size?
NNT is used for calculation of sample size, but it is not a universal decision to calculate, because there are more other factors for calculating sample size, like effect size, like your power of the test. They are different things. If you ask me frankly, number needed to treat is not a very robust method of calculating the sample size. The more better methods are based, of course it depends upon the research question and on your design and your specific aims and objective.
So how are we reaching the figure
Thank
of
you, sir.
7.5?
Yeah. I can't hear.
Sir, how are we reaching the figure of 7.5?
1 divided by the risk difference.
Okay, sir.
You see the formula equal to 1 divided by M139. So 1 divided by 0.14 times T, that becomes 7.5. So
Sir,
what
can
Dr. Sumit said that number needed to treat is 5 is acceptable, and number needed to treat in between in some cases 7 to 10 is also acceptable. But anything beyond that, that means that the problem is little bit on a severe spectrum or on a severe side. Can I move forward now?
Sir, can you
Yes,
interpret
sir.
the risk difference once again?
Oh my God. Can anybody help? Okay. Risk difference means what was the risk of diarrhea in the group where no counseling was given? What is the extra risk attributable? That is the risk difference. See, difference means we are taking the subtraction, we are subtracting one thing from another. So when I calculated the risk of diarrhea in one group where no counseling for breastfeeding was given, there it was 33%. When we calculated the risk of diarrhea in the group where counseling for breastfeeding was given, it is 20%. So the absolute difference, that is 33% minus 20, becomes 13%. That is the risk difference. Is it clear? Hello.
Yes, sir. Thank you.
Okay. Now I am leaving this exercise, not demonstrating this one. You all can calculate because I have already demonstrated it. Uh, I think this can be this can be also easily because Dr. Sumit has already demonstrated this complete thing, that how to go about it, how to calculate it. Okay, I'm trying to. We do have time, and we can demonstrate this. So what? See, when I have a 2 by 2 table, I am increasing my size of this.
So can I ask you a question?
Yeah.
So in the second one where you have relative measure of association, first one is showing risk ratio in of diarrhea, second one is also showing, then the last one is showing odds ratio. Shouldn't it be the relative risk?
What odds ratio? Where odds ratio?
The lower one.
Yeah.
Yeah, here. In the third
No,
one.
it is there. I have just given it to calculate for practice कि relative measures में ये सब चीजें होती हैं. That's the purpose only.
No, odds ratio would be required for odds, not for the risk ratio, isn't
Yeah,
it?
yeah, you can get it. My only purpose was that to combine in one exercise everything, but technically and scientifically you are sound. Matlab, you are right.
Okay.
So, so what I do in this, once you have to calculate the cell frequencies count or the sum, what you do, you select the first to this position by pressing shift and right arrow key, go a step right more, then go shift right down, and then one more down, and click on, there is a symbol here which is summation. So this is there, and in this way, when you select and click on this summation sign, we get the all the values. Now it is there. Now can anybody tell me quickly how to calculate sensitivity, specificity, and all other parameters? How can? Yeah,
Sensitivity is equal to 130 divided by 200.
130 divided by
A upon A plus C.
Yeah, and if I need to express this in percentage, I
In
can
200.
enclose this in parenthesis, and I can type 100
Multiply into 100.
or 65. What does this mean?
This means the test identifies has 65% sensitivity, means it's a test is able to identify the 65% of the true positives.
Yeah, true positive. In the same way, when you want to go for specificity, it will be this
150,
position
150 divided by
divided
200.
by this
200
one and
into
multiplied by
multiplied
into
by
100.
100.
Okay, thank you. Now, can anybody volunteer for how to form the positive predicted value? Yogita?
So 130 divided by 200.
No, it's 180.
No.
130
divided by
sorry.
180.
180 into 100.
Hmm.
Then for negative predicted value,
150 divided by 220 into 100.
are you sure? It is
Yes,
150 or 70?
70 divided by 220.
Negative predicted value.
Sir, it is D. D divided by D. Yes,
150. 150.
It is 150 divided by 220.
220.
Because in this you want to find out among those who were being tested negative, how many of them were actual negative.
True negatives.
Okay, so it is this. Now how to calculate the value of false positivity? False positivity is 1 minus sensitivity. So I have to write in fact 100. 100 minus this, and false negativity is
100 minus specificity.
100 minus, in fact I will just complete this as 100 here, so I can write the function here.
Excuse me, why is it 100 minus and not 1 minus?
I am expressing this in percentage, that's why.
Okay, sir. Thanks.
Okay, is it clear? Now there is one thing more, diagnostic accuracy. Khurana ji, can you interpret how to calculate diagnostic accuracy? And what does diagnostic accuracy means? Anybody? आप लोग थक गए क्या भाई?
So prevalence?
How
So
to
prevalence?
Sensitivity divided by specificity.
What does diagnostic accuracy means?
The ability of the test to identify correctly true negatives as well as true positives among the total.
Yes. So what will be that among the total patient? So that becomes equal to this. Means those who were positive, HIV positive by ELISA, and those who had a CD4 count of less than 300 for HIV status positive, that is 130. In the same way, that is A, that is then A plus D divided by the total sample size, which is 400.
Into 100.
Into 100, if you type 100, that will give you the percentage. Okay. So what does this mean? 70%. What does 70% means? Yogita, can you tell me what the 70% means?
इसका मतलब है कि जो हम जिस टेस्ट के थ्रू हम चेक कर रहे हैं HIV का स्टेटस, वो 70% एक्यूरेट रिजल्ट देता है.
इसका मतलब
इसका मतलब
Reliability of the test.
Yeah. Please go ahead. Somebody was trying to say something.
Okay, sir, does it mean the reliability of the test it is 70% reliable?
We can say to some extent. What it means that if we are testing 100%,
70 will be
70% will be correctly classified. That consists of your true positive as well as true negative. Okay. Anybody has to ask anything till this point? Thank you, ma'am. Thank you, ma'am, for giving this cooperate for this interpretation, because I can't follow both the things simultaneously, so that's why it was there.
Hello, sir.
Yeah, sure. Go ahead.
Sir, in the false positivity, won't it be one minus specificity?
Yes, 1 minus specificity in the false positivity. मतलब अभी मेरे को फॉर्मूला मतलब वो हो रहा है, but I think it is fine.
Yeah, because we have converted it into percentage. I think that's
you have
why.
percentage into percentage, na?
Yeah.
Sir, I am not telling sensitivity. I am telling specificity. 100 minus specificity, if we are talking about percent. Since in specificity only we consider the false positive, in sensitivity we consider false negative.
Okay. False positivity and false negativity. What will be the false positivity? False positivity are those cases who were negative but they were actually tested positive. इसका मतलब यही हुआ ना? False positivity means they have been tested positively false. That means by ELISA, they are negative, but they are being set positive. So what does this mean? अरे भाई कोई बोलेगा, कुछ भी बोलो तो ना.
Person would be having AIDS if he is tested false. Wait a
No,
minute.
it's false positive.
If it's false positive, sir, then the person is not having AIDS, and if it is false negative, then the person is actually having AIDS.
What should I type here?
False negative.
Huh?
False negative.
False positive.
The person wasn't actually HIV positive, but he was tested positive. Erroneously tested
I
positive.
can't hear it. Little bit louder, please.
So the person was erroneously tested positive.
Okay. The person was
like he wasn't actually positive, but the result came out positive.
Yeah. So what should be written here?
As in the formula, sir.
Yeah. I think I wrote the correct formula. Let
100
me
minus sensitivity.
But it should be 1 minus sensitivity, I think. Yeah.
1 minus sensitivity only, I think so.
Yes.
I did the same thing probably.
So it has to be 50 divided by 200, false positive.
I don't think so. Okay, ठीक है. चलते हैं. And this one would be false negativity is
70 divided by
70 divided by 200.
200.
220 नहीं होगा.
No.
Yes, fine. Okay, now can I move forward? Hello.
Yes, sir. Yes, sir.
Now how to calculate this? Can anybody guide me? Suppose I don't know how to do this. Assume that I don't know it. How to do it?
Sir,
Yeah.
can you please explain false positivity and false negativity one more time?
False positivity is 1 minus specificity and false negativity is 1 minus sensitivity. How to go for this? Can anybody tell me?
सर ये कैलकुलेट कैसे हुआ है सर? एक बार प्लीज इसका कैलकुलेशन हमें टेबल के थ्रू दिखा दीजिए.
ये है.
हाँ, एक बार कर दीजिए ना. फॉल्स पॉजिटिविटी मतलब F161. F161 क्या है सर? एक बार इस पे डबल क्लिक कीजिए ना.
मेरा क्या हुआ कि नहीं? 5 मिनट तेरे मगरिब का काम आया. मगरिब के टाइम के बाद खाने का टाइम.
हाँ, अभी समझ में आएगा. फॉल्स पॉजिटिविटी मतलब
False positivity means that actually by gold standard they were negative but they were tested positive.
हाँ सर, वो कॉन्सेप्ट हमें समझ में आ रहा है, हमें कैलकुलेशन समझ में नहीं आ रही. एक बार उस पर डबल क्लिक करके हमको देखना है. मतलब they were positive and
Sir,
tested negative.
100 minus
So it will be 100 minus specificity and 100 minus sensitivity.
That's what 100 minus specificity is done. 100 minus 75 is 25 and 100 minus 65 is 35.
Yeah.
Okay.
अच्छा, okay.
Can I move forward? Anybody
Yes,
want to
sir.
ask something else? I have increased the font size. Now it should be visible. Can anybody solve this or should I give this as exercise?
Exercise.
Exercise, sure.
Yes, sir, definitely.
Sir, basic formulas हैं हो जाएगा.
ठीक, okay. ठीक है, तो this is an exercise. So this completes the day. I think many of you would be. I think that many of you would have followed. I can understand there is a little challenge in addressing everybody, but we have tried our level best to explain the things and because creating such files for practice is a little bit tedious and it takes time and there. But I hope it makes some sense and you people will be benefited by this. So anything, I think everybody was able to download and practice it. Many of you.
Sir, one last
Yes.
time. Sir,
Yeah.
one last time, please elaborate the sensitivity. Just one last time. It is 65. How did you calculate?
65 sensitivity is what is the probability that an individual or the individual are positive and a particular test also declares them positive. Okay, so it is total of 200 individuals were tested positive.
Okay.
ELISA is a gold standard.
Okay.
Out of 200, 130 individuals were those who were also classified as HIV positive on the basis of their CD4 count.
Okay.
So that is 130 by 200, that becomes 65%.
Thank you, sir. Thank you, sir.
Sir, I have one question, last question.
Yeah.
In diagnostic, accuracy, sir,
Yeah.
when we are calculating that, for every new set of symbols, we should add an extra bracket, sir.
Yes, it's advisable.
Oh, okay, sir, because I got other value. Okay, sir.
Anything else? Anybody else? Good luck. Diagnostic accuracy formula, please. A plus D divided by A plus B plus C plus D. Which is more dangerous, by concept T1 or T2? There is a separate section tomorrow. I will be devoting 2 hours to all this. Anybody else would like to ask anything? Since you have asked, type T1, type 1 error is more dangerous. And why it is more dangerous, that we will be discussing tomorrow. How you all people find this exercise?
It's very good, sir.
Only to one people.
Very useful, sir.
Very well made. Fantastic, sir. This was the best session till date.
Yes,
Thank you. Thank you. It takes time. There is a question, rate ratio versus risk ratio. Rate ratio and risk ratio. There is a difference between a rate ratio and a risk ratio. That already Dr. Sumit has explained. I am little bit dying out of energy today because I am little bit tired from today. Because I haven't prepared my lecture till now and I have to, and the coming 3 days are of mine. That's why. So I am trying my level best to commit whatever I promised to you people in the first day and second day. Anything else? Otherwise it is for a day and there are no couple of announcements to be made today from my side.
Excuse me, sir.
Yeah.
Excuse me, Ashwani, sir.
Yeah.
Sir, your session is very informative. Thank you so much.
Thank you. Thank you.
Excuse me, sir.
Yes, Yogita.
I'm sorry, sir, but can you please
Yogita,
explain?
I will make you one of the speaker for coming days. Don't worry. Yes, please go on. In fact, Yogita has worked with us in the All India Institute of Political Sciences. That we will be elaborating a little bit more. So we know. Yeah. Yes, Yogita, please go ahead.
Sir, I think I'm confused again. Sir, can you please explain one more time for false positivity?
False positivity में क्यों कंफ्यूजन हो रहा है आपको?
सर हमें कॉन्सेप्ट का नहीं प्रॉब्लम हो रहा है, हमें कैलकुलेशन में पता नहीं क्यों लग रहा है कि कुछ गड़बड़ है.
हमको भी लग रहा है कि कंफ्यूज किया है लोगों ने मेरे को. मैं पहले सही किया था, बाद में लोगों ने मेरे को लग रहा है उल्टा कर दिया है.
It's basically 1 minus specificity.
स्पेसिफिसिटी क्यों होगा फॉल्स पॉजिटिविटी?
I think it is 1 minus sensitivity.
सेंसिटिविटी होना चाहिए. सर फॉल्स पॉजिटिव मतलब टोटल फॉल्स पॉजिटिव डिवाइडेड बाय n, I think
it should be 70 divided by 200.
हाँ सर, और यहाँ पे ये 35 और 25 उल्टा हो गया है. हम बहुत देर से परेशान.
वही मैंने जो पहले किया था मैंने वही किया था.
यस सर, ये आपने पहले वही किया था।
सबसे पहले मैंने वही किया है, फिर somebody said this, तो I got little bit कि हो सकता है मेरे से कुछ गलती हो रही हो, but I that's what was in my mind. Pratibha, you had a formula. Can you comment what?
I'm sorry to interrupt here, sir. Actually, false positivity involves
No, we know what it
specificity.
involves. So tell me the formula now.
1 minus specificity. So one minus specificity. According to the book.
Okay. 1 minus specificity.
Yes.
अच्छा सर, हमको एक चीज बताइए, इसमें से करेक्ट HIV कौन सा है, CD4 काउंट वाला या एलिसा वाला?
Whatever is the gold standard, that is the column.
हाँ, ओके.
And whatever test we do, that is in the row.
अच्छा सर, तो ओके, एक तो 1 माइनस स्पेसिफिसिटी या सेंसिटिविटी जो भी है, फॉल्स पॉजिटिविटी का मतलब होता है कि टोटल केसेस जो कि फॉल्सली पॉजिटिव हो गए हैं, राइट?
False positivity means that actually they were negative by the gold standard, but they were being tested positive by the specific test.
ओके सर, तो इस टेबल में वो नंबर कौन सा है? क्योंकि हम गोल्ड स्टैंडर्ड के हिसाब से पॉजिटिव है 70 और ग्रेटर देन 300 CD4 काउंट. आई एम सॉरी, हमें HIV के बारे में ज्यादा आइडिया नहीं है, इसलिए हम कंफ्यूज हो रहे हैं. सर, इसमें वो नंबर क्या है, फॉल्स पॉजिटिव नंबर क्या है यहाँ पे, जो एक्चुअली में ट्रूथ नॉन पॉजिटिव है, नेगेटिव है, लेकिन
70 is the false positive number.
ओके ओके, थैंक यू सो मच. 70 is the false positive number.
And why 70 is the false positive number?
No, it will be 50.
Because I'll tell you, sir, by Elijah 70 people were declared positive, but actually they were negative because HIV negative by the CD4 count. Their CD4 count was more than 300. So, but by Elijah they were declared as positive.
50 is false positive.
50 is false positive, right? 50 is false positive. The formula should be 50 divided by 200. 25 is correct, sir. 25 is correct.
Then it's
50 are HIV negative by Elijah. So they are false negative.
False positive means, talk about false positive. False positive
And
means the person.
Elijah and not CD4 status.
No, CD4 is the gold standard.
No. That is the reason. Elijah is this standard test. As
Exactly.
Here, Elijah is the gold standard.
Exactly. Elijah is the gold standard.
We put in this way, na?
No, sorry, Elijah is not the gold standard by any means.
Just read the question, sir. Just read the question. They are asking about the diagnostic performance of CD4 count Elijah.
This is statistician's video.
May I revise it?
Yes, sir. Please.
If I'm permitted.
Yeah, sure. Why not?
Yeah. Just whatever you have explained is very well explained, and it's a very good presentation. But just whatever has been explained, I just, for the clearance of the other colleagues, I just wanted to add here that Elijah is a gold standard in this case, and CD4 count is a test. Now, out of these total tests, 400 tests are tested, and CD4 count is the test by which we are classifying them into two categories. Now, the Elijah positive and this Elijah positive and Elijah negative, they are gold standard now. Now, just to understand this table, the total number of 400 samples, they are classified into positive and negative. Now, 200 are positive by Elijah and 200 are negative by Elijah. Now, just to understand the sensitivity and specificity, the sensitivity is, what we wanted to say is, जितने पॉजिटिव एलिजा ने बताए उसमें से कितने पॉजिटिव हमारे CD4 काउंट ने क्लासिफाई किया. जितने टेस्ट एलिजा ने पॉजिटिव बताए उसमें से कितने पॉजिटिव एक्चुअली में है, तो वो हमारा क्या हो जाएगा, 130 हमारे पॉजिटिव हैं जो एलिजा ने बताए और हमारे टेस्ट में भी बताए. तो 130 डिवाइडेड बाय 200 हमारा सेंसिटिविटी हो जाएगा, बड़ा क्लियर है. और स्पेसिफिसिटी क्या हो जाएगा, वो हो जाएगा जितना एलिजा ने हमारे को नेगेटिव बताया उतना हमने उसको क्लासिफाई किया बाई CD4 काउंट. तो 150 बाई 200 हमारा स्पेसिफिसिटी हो जाएगा. यहाँ तक तो कोई दिक्कत वाली बात नहीं है. अब आई बात पॉजिटिव ये फॉल्स पॉजिटिविटी और फॉल्स नेगेटिविटी। फॉल्स पॉजिटिव क्या है? फॉल्स पॉजिटिव में जो टेस्ट हमारा गोल्ड स्टैंडर्ड ने पॉजिटिव बताया है उसको हमने पॉजिटिव नहीं बताया। जो भी गोल्ड स्टैंडर्ड ने बताया है उसको हमने पॉजिटिव नहीं बताया, तो वो हमारा फॉल्स हमारा नेगेटिव हो गया। और
So
जिसको
what
गोल्ड स्टैंडर्ड
what you are saying is exactly correct, but here the question is which you will take as a gold standard. I'll tell you, ELISA is made thousands of company and you have to test their diagnostic value, while CD4 count is a universal phenomenon and it will remain same everywhere. So
Sir,
you
just a
cannot
minute.
test the
Sir,
diagnostic value of CD4 count. You have to test the diagnostic value of ELISA.
Sir, for the present question, we should not go into debate which is the gold standard, which is not. In the question, what we have to assume is the gold standard.
See, just a minute. The purpose of giving this question was just how to calculate the parameters.
Yes.
Maybe
yes,
the
that is
row
true.
or the columns would have been a
Yes.
little bit interchanged because you are not the expert in this CD4. But at least I am not the expert in CD4 and ELISA. So, but that's from the purpose of, I think what I demonstrated for the first time was correct according to me.
We are not debating here which is the gold standard, which is not the gold standard. It is how to calculate the sensitivity, specificity, positivity
Let us
value.
all assume that
That is
ELISA
the
is the
question.
gold standard in this question, and let us do the calculations.
Yeah, that's the point. Just for the purpose of demonstration that was being taken.
Yes.
Please complete, Sharma ji, please. Dr. Sharma, please
So,
complete.
shall I continue, sir?
Yeah, sure. I am saying please continue.
Yeah. So the now false positivity is there. False positivity is where the gold standard says it is positive, but our test, whatever test is there, it says negative. Then it becomes the false positive, false negative. Now, if the gold standard says it is negative, gold standard, I am not debating about the ELISA or anything else. If the gold standard is negative and we are saying that it is positive, then it becomes false positive. So the false positive in this case will be, if you consider ELISA as a gold standard, so it will be false positive will be 50 divided by 200. The 50 is B cell. B cell divided by the total 200. So this will be 50 divided by 200. And false negative will be this C cell. C cell is 70. 70 divided by 200. This will be our false negative. So this is, there is no confusion in that. So we should not go into debate of which is the gold standard, which is not gold standard. But to understand the question, we should take as a gold standard and the test. So whatever gold standard is there, among them, how many are positive, truly positive? Out of them, actually positive are there, that will consider as sensitive. So there should be no confusion.
But sir, value will change when you will consider CD4 count based diagnosis as true or ELISA based count diagnostic as true. So the value will definitely change.
You are right, sir, but let us assume for the sake of this exercise that we
for
are
the sake of
considering, we all are
exercise, we should not
considering
go into debate
ELISA
of-
as the gold standard now.
You,
Just for the sake of exercise.
then
I
this
think we can do it.
calculation has to be redone.
Yes, sir. For the
Hello,
sake
sir.
of
May I say something?
That's was exactly I did
No,
for the
calculation-
first time based on that. Okay, let me give just
Sir,
a second.
let's decide that okay, whatever they are saying, ELISA based diagnostic is true, and the exercise will be submitted based on this one.
Yeah. I will request Professor Kocher to please say something. I think she has been kind enough to explain the things.
Sir,
Yeah.
in this case, because this is a kind of a maybe hypothetical question,
that's right.
so therefore there could have been some error in some labeling or like that. But technically, CD4 status means that when we do the cell count of the lymphocytes, which are the cell-mediated immunity, and cluster-dependent 4, that is the identification for the HLA cells. There are some other clusters also like CD9 and CD26. So therefore, at the final diagnosis level, it is the CD4. ELISA is something which is a lab test, and which is calibrated, and because it is easier to do and feasible to do, so therefore ELISA is kind of considered the standard as a laboratory investigation. But the final diagnosis which is written on the leftmost column is that we are seeing 300 less than 300 HIV positive and more than 300 HIV negative. So what does ELISA say about them? So here the point of reference is the accuracy of ELISA, whether it can correctly pick up or it falsely picks up or it misses the diagnosis. So as a statistical problem, yeah, we can take that. And maybe sir, what you said in the beginning was the correct one, because I think cognitively also we all are kind of tired of थोड़ा सा मन में सबको वो थोड़ा सा हो
नहीं,
रहा
वो
है
मेरे को लग रहा है कि
overloading.
सबसे
हाँ
पहले
जी
जो मैंने किया था वो सही किया था, बट ठीक
हाँ
है,
जी
that
हाँ
is
जी
that interested that inculcated discussion, so that was nice to see that everybody was active. I appreciate that,
but at
and that's
least
the purpose.
everybody now can go home and as a homework read these are the very very basic concepts. And many of this, if we are involved in other kind of multitasking ki hum chat bhi पढ़ रहे हैं साथ साथ और हम सुन भी रहे हैं और हम देख भी रहे हैं, so maybe we everybody can't keep pace, we are each different. So I think once we have some rest and everybody
Yeah,
opens
sure.
up that downloaded one, and it will be correct in everybody's mind.
Okay, thank you, ma'am. Thank you, ma'am. Thank you. So this is from my side today, from for today, and मतलब just to reiterate, I have already reiterated many times. We are getting many requests that many people are sorry unable to join, and that we have just stopped listening to all those so-called different reasons. Everything is system enabled, everybody has got the mail, so whosoever is a registered participant, they will be joining through that only. So everybody may be interested in some different exercises or some different sessions, they will be joining at their own ease and at their own comfortable. That is acceptable to us. Regarding the certification or everything evaluation, everything has been declared, everything has been made clear, uh, and our purpose will be to give certificates, but there are certain provisions of evaluation and contain and something are based on that. For them we will be releasing the certificate. We can't give certificates to individuals who have just attended one session or for a one day and not submitted all the assignments. At least submission of all the assignments in the mandatory requirement for getting the certificates. That's from my side. Anybody has any confusion, any apprehension regarding this, or any suggestion to discuss or debate? I am open with that. Anybody has to say something?
Sir, any other announcement for today or tomorrow's session?
My only request that as far as people joins for the coming 4 days, it will be beneficial for them because everything is different. Any specific announcements is not there, only a request and urge that as maximum people joins, it will be more beneficial for them and even for us.
Right, sir. Good night for today then.
Good night. Good night. Good night. Thank you. Thank you.
Sir, a small question. Sir, the assignments are time limit or we can do them at our own
We
pace?
have already communicated in this regard yesterday. It is becoming little difficult to communicate everything again and again. But once again, I am saying all the assignment has to be submitted within 1 week from the closure of this workshop.
Sir, that तो I know. I was actually asking कि उसको करने के लिए बस ऐसा तो कुछ नहीं है ना कि आधे घंटे में फिनिश करना या 10 मिनट में फिनिश करना. That was my question.
आप अगर 1 मिनट में करके जमा कर सकती हैं तो कोई दिक्कत नहीं है. आप 1 दिन में कर सकती हैं, कोई दिक्कत नहीं है. But हम
We
लोग
have
को
also
चाहिए.
mentioned the date for submission. That is 30th on the portal too.
Thank you, Amit. Thank you.
Excuse me, sir. Sir, it's a bit. I know it's a bit late to ask, but diagnostic accuracy. If you could click on that cell, I could find like how to find it out. I got little messed up with that false positivity and negativity stuff because of that.
Yes, I have clicked on that. It is there. I haven't annotated. Somebody else had annotated the screen.
How did we reach at that 70? That was my doubt.
I demonstrated this very specifically. It is this 130 plus 150 divided by 400.
Okay, thank you so much, sir.
All the positive cases, all the true positive cases, all the true negative cases divided by the total grand total.
Okay, thank you, sir, so much. Thank you so much, sir. Sorry, sir.
Yeah, please go ahead. Somebody
So,
else? Yes, Dr. Purva. Hello.
Approval thing. I had submitted one. I had submitted one assignment, and it is showing approval pending. So what does it mean?
Ma'am, we need some time to do all the things.
Okay.
Everything
Okay.
can't be done with a click of a
Yes.
mouse.
Yes. Absolutely. Okay. Thank you, sir.
I have also told yesterday, whenever you submit your assignment, it is held for approval. Approval means the faculty will check, then it will be only approved.
Okay. Thank you for the explanation. Thank you.
Excuse me, sir.
Yes.
Sir, we have to submit only that Word file or just this Excel sheet as well?
After
As
what?
assignment.
I didn't did any exercise on what file today. It is only on Excel.
No, sir. I have downloaded one file which have that 5 questions. It is in Word file. So we have to submit that also, or just this one?
I haven't given any exercise on Excel. What file is for software installation, I think.
No,
Sir,
sir. There
Sir,
was
it's
by
parameter.
Dr. Rao, I
Yes,
think
sir,
she
there was
stopped.
a questionnaire, and we have to submit it. So you please submit it, madam. It is written there clearly.
Yeah, assignment on research design. That one I was asking.
Yeah, yes, it is a Word file. It is.
Okay, fine.
It is here to just submit the research design.
That was for day 5. Okay,
Yeah.
fine.
Anything else?
Sir, I think research design is now for day
It is
4 now.
shifted. That's what I am about to say. Research design is shifted to today.
Day 4.
Yeah,
It
day
means
4. That today research design and this categorical data analysis, which has been done for today, because research design is based upon epidemiology on the session which was taken by Dr. Ravindra Rao. We have the assignment for that. For on day 4, it is written. There is a Word file and there is an Excel file. Both has to be uploaded. Ameji, will they be able to upload both the files in the same browser section?
for the day 4 or day 5?
For today, if there are 2 exercises, then one is in Excel and one is in Word.
Okay. They are able to upload up to 5 files.
Okay.
So there is no order.
Okay. Anybody else would like to ask anything?
Any requirement for mentioning name or email on the assignment submission?
Yeah, that's I forgot. Everybody is expected to write their names in that.
Okay.
Even it would be better if you change the file name and append your name in the file name. That would be the better idea even. So you can do both.
Okay, sir. Okay, sir.
Anything else? Anybody would like to ask something?
No, sir. It's better that you take some rest.
No, I will not be able to take the straight 23. I know that.
Okay, sir. Thank you very much.
Thank you.
Thanks a lot, sir. Take care.
Thank you. You all too. Thank you.